Mimi kwa majina naitwa Crispinas Kuku Wafula, ni mkaaji wa Dagoretti North, lakini kwetu kule ni Bungoma County. Natoka sub county ya Bungoma South. Mara yangu ya kwanza kwa experience maneno ya SHA kufanya kazi ilikuwa last year, His Excellency, ambapo sister yangu alikuwa mgonjwa. Wakati alikuwa mgonjwa, ali have to undergo surgery kule Riale Hospital in Eldoret. Alikuwa anafanyiwa surgery, alikuwa na fibroids of which tulitoa uterus. Na SHA ilitusaidia katulipia 98,600 November last year. Mgonjwa anaitwa Violet Muyoka na Lianya. SHA imekuja kanisaidia tena. Mimi mwenyewe nilikuwa mgonjwa Mechumeru Health Hospital. It is a health center, ilikuwa dispensary, lakini sasa is a health center. Of which nilikuwa mgonjwa malaria, nikalazwa 3 days mwezi wa 4, na SHA ilinilipia 20,000. Si kutoa kitu hata ndururu wakati nilipeana ID yangu. Tena juzi last month tarehe 13, sister yangu ambaye anaitwa Caroline Faiza Simiyu alikuwa amenitembelea hapa Kaongware, akawa mgonjwa, nikamkimbiza hapa Luton Hospital, iko Nairobi County, opposite Coptic Ngong Road. Nilipofika hapo, madaktari wa hapo waligundua alikuwa na septic shock. Sasa mambo ya septic mimi sijui, mimi si daktari, mimi ni driver tu. So alipopatikana na septic shock, tukamweka hapo. SHA before tumadmit, His Excellency hakukuwa na SHA. Pale hospitali waliniambia endeni umregister SHA ndio urudi. Kwa kweli Luton Hospital, kutoka Luton Hospital mpaka SHA office center hapa hill, it is 2 km. Nilienda na ID yake, nikaenda na simu yake, mimi nikamregister. Compared to SHA to NHIF kitambo, haingefanya kazi immediately mgonjwa akiwa anafanya kazi. Hata kama ni kizuri tu. Tusione kizuri tuseme ni kibaya. Nilimregister na nikakuja nikamwadmit na SHA. SHA ilinisaidia pale hospitali, tayari sisi alifanyiwa 2, SHA ikalipa yote. CT scan SHA ililipa yote. Alikuwa ICU for 12 days. SHA ilikuwa inatulipia 28,000 here at Luton Hospital. Wakati tulimdischarge, SHA ilitulipia 369,600. Mimi ndio niliadmit sister yangu. Thank you for SHA. Na in summary, Mr. President, nataka kueleza kitu kimoja. SHA is working. Lakini shida ni moja. Ni pale kwa mahospitali ndio kumeosa. Kwa sababu vile nilikimbia kwa SHA office, walinihutumia within 10 minutes. Nimeenda nimeadmit sister yangu na SHA, na tulilipa mwaka mzima 1,000 ngapi? 6,000, His Excellency. So naomba tu mwenye anasema SHA haifanyi kazi, hacha konjeka. Lakini siku utakuwa mgonjwa, utaona kweli SHA inafanya kazi. Alafu upande wa SHA kuna kitu inaitwa system developer. What is system developer? Mimi niko hospitali, nimekuja kuadmitiwa, na kufika hapo kwa mashini ya SHA wananiambia system. Lakini sio system, wanakuangalia kama una pesa, utumie hiyo pesa, kutanganyia ni system. So Mr. President, wakati ukiwa Minister of Agriculture, ulifanyia kazi kwa shamba. Minister of Education nikakumbuka, ukafanya nini? Ukashukisha from P+ ukaleta C+. Sister yangu saa yako university, Mr. President. So ni yeko kuu. Sasa ambia hawa maminister tafadhali, msilete Mr. President down. Kwa sababu ya nini? Yeye ameimplement. Tafadhali simuendeleze tu. Kwa sababu tukiangalia kama level 4 hospital, ukienda huko utatibiwa kila kitu. Lakini Mr. President, jana ulisema kuna mashini ya MRI nini. Chusi nimeenda one of the county hospital, I think His Excellency Governor wa Nairobi uko hapa. Nilienda Mbakati, na mgonjwa mimi ni mtu wa upa. Kufika huko X-rays walinituma Luton Hospital. Ni nini kinaendelea Mr. Governor? Tusaidie tu kwa sababu president anaweka bidii. Au watu wako wa ground Mr. Governor, uko na Minister of Health Minister mwenye anasimamia hospitali. Mwambie atoke kwa ofisi atembee, mfuate nyayo za His Excellency Mr. William Samoei Ruto. Thank you.
Thank you. Thank you. Asante sana. Asante sana kwa kutuzungumzia. We'll take all the comments and then at some point we will respond to all of them so that we get as much feedback as possible from all of us who are here. We have somebody with a lived experience from cancer. Somebody with a lived experience from cancer. Where are they in the room? If they are here. Asimame tafadhali. Yuko pale. Sawa.
His Excellency, Mr. President. My name is Esther Wanjiko, a stage 4 breast cancer survivor, and this is my 4th year. Niko mbele yenu na mbele ya wananchi wote wa Kenya nikisema vile SHA imenisimamia. Kila mtu anajua kansa, jeni ya kansa vile ni ngumu. Na mtu akisikia mtu ako na kansa unaogopa. Na wewe mwenye umeshikwa na kansa unagojea kukufa. Sababu ya live experience yenye watu wameshapitia. Lakini niko mbele yenu kusema kansa inaponywa, inapona, na usiogope kutibiwa kansa sababu SHA inasimamia, na mimi am a beneficiary, and I thank God and I thank you Mr. President kwa kuleta hii scheme ya SHA. Cancer patients wanajua vile ni gumu sana, na ile treatment mimi napata ni very expensive, na ni among the most expensive treatment kwa breast cancer. Natumia dawa inaitwa Herceptin, na nikianza treatment 2023 it was costing 135,000 after 3 weeks. You are supposed to take that medicine after 3 weeks. Now wakati huo sikuwa na pesa, na hiyo scheme nyingine ilikuwa inasimamia treatment ya cancer, so I had to do a fundraising which costed me iligaramika tu, ilinisimamia tu just 2 sessions. So after that nilikaa tu nigoje nikufe, but fortunately nikakaa after sometimes bila treatment na nika give up. Hatimaye nikaongeleshwa na watu, nikasaidiwa na watu, tukaanza kwenda the kienyeji way. But wakati SHA ilikuja ndio nilianza treatment, na even now I'm under treatment. Hiyo accept tunapata saa hii tunapata weekly, na through collaboration ya SHA with the government with La Roche, hiyo treatment imepungua mpaka from 135,000 to 40,000, ambapo SHA inasimamia everything. Kuna dawa nyingine tunatumia inaitwa Zoladex. Saa hii iko bei kali, tunaomba pia ishukishwe ndio tuweze kupata dawa. Pia saa hii ukienda kwa kila boma in Kenya, hakuna mtu utasimamisha hata kwa barabara umuuliza kama ako na rafiki ama familia imeguzwa na ugonjwa wa kansa. Kweli si kweli? Ni ukweli. Kila familia, kila mtu kimsimamisha atakwambia rafiki yangu ako na kansa, mama yangu ako na kansa, baba yangu ako na kansa, brother yangu, anyway. Kansa imekuwa ni kama disaster. So tugeomba hata kama SHA inasimamia, wacha dawa zikuwe free kama za HIV. Tuko tayari kukunywa dawa. Dawa ndizo hazipatikani, na wenye wanapata ziko very expensive. Wacha hiyo tu ya Herceptin peke yake. Zingine tunatoa kwa pesa kwa mfuko. Situmii Herceptin peke yake, natumia dawa inaitwa Zoladex, natumia Anastrozole, natumia na dawa zingine. Then Mr. President, kuna hii after treatment kuna palliative. Umemaliza treatment ndio, umeambiwa uende nyumbani. What next? Sisi tumerudishwa nyumbani, sio mimi niko under treatment bado, but sisi nasimamia cancer patients. Sisi wenye tumemaliza treatment tuko under palliative care, lakini hatuna uwezo. Unaambiwa uende ukule vizuri, hata hiyo mkate ya asubuhi huwezi afford. Unaambiwa kula a lot of greens, hiyo hata pesa ya kupata hiyo greens hauna. Kazi ulifutwa, bwanako walikutenga, bibi yako walikutenga, kazi imekwisha na uko nyumbani, utapata hiyo matibabu na hiyo chakula namna gani? So tunaomba, kama umeshikwa na kansa na ulikuwa umeajiriwa, tupatie tu nafasi nyinyi waajiri wetu, tufanye treatment, then tukuje tuendelee na kazi yetu, sababu si kupenda kwangu kugojeka. Na pia wewe unaweza gojeka. Usinitenge sababu niko na kansa. Usiniweke kando sababu nimeshikwa na kansa. Kansa si ya mtu na hakuna mtu anaitisha. So tunaomba after cancer, please, kuna palliative, tusimamiwe. Another thing, vitu zimekuwa bei kali. Mimi ni patient wa KNH, Kenyatta National Hospital. Tumeongezwa pesa ya kuona daktari from 1,050 to 1,550. Tulikuwa tunakosa hiyo 1,000. Tumeongezwa 1,500. Ni wengi hata wanakosa mpaka transport ya kutoka kwa nyumba kwenda kupata hiyo treatment. Then nimemwambia aongezewe 500 from 1,050 to 1,550. Tunaomba hapo utuangalilie vizuri. Tunaomba sana sana.
Shukran Esther. Asanti kwa kutuelezea your own experience. Let me at this juncture, do we have any of the...
Okay. Maybe before we go to the next, just for clarity. Shikuku has said we need to do more to make sure that equipment are available in more of our facilities. I know we have a program with our county governments. Yesterday, the faith-based hospitals also said if it is possible for us to consider them in the supply of equipment under our NEST program, it would be a good thing. And I think that is what Shikuku was saying, that we need more facilities with the correct equipment for purposes of treatment. Waziri, would you have some ideas on how we can make equipment much more available in more hospitals? What is the strategy? Because I thought we have a plan.
Your Excellency, let me talk for the public health facilities, those which are under the county governments and under the national government. It is very easy to place equipment, and we have done that in over 239 facilities across the country in major equipment. We are only having a MRI in 2 facilities, which we now intend in the next 1 month to upscale to about 20. So we get requests from our county, our counties, because we have signed an partnership agreement between us, the national government and the county and the vendors. And we are going to now reach out to the faith-based. But just on 2 things, and I'm very happy the lady who was speaking on behalf of the cancer patients. The reduction, the cost of care in Kenya is a problem we must all discuss. Government, the private sector, pharmaceutical companies. And what she says from 135, that particular drug, to 40, is as a result of an MOU the Ministry of Health have signed with Roche, one of the biggest pharmaceutical companies. And we are going forward to do the same with Pfizer. Pfizer, as a pharmaceutical company, supplies most of the essential medicines in our country. So the president of Pfizer is coming to see you next week. But I have done a rider that before he comes to see you, the condition is that of the essential products that his company sells to Kenya, there must be a price reduction. So Equipment, Your Excellency, I agree. We are going to upscale. Finally, Shikuku said about system, and I agree with him. There are facilities that tell our citizens that the system is down. And I want to give this to Anthony, and Mercy knows. Our systems downtown is very fast, and facilities level 5 and 6 and even up to PhD, we can tell. But there are facilities in our country, and I really want to speak to our citizens. Do not fall into the trap when you are told the system is down so that you pay out of pocket. This is a message we must pass to our Today, out of the 44 counties, 39 counties at least have one CT scan in their sub-county referral hospital. Some have two, and I'll give the example of Bungoma. In Bungoma County Referral Hospital and in Webuye. Nairobi, I'm sure Governor Sakaja is here, and this morning we had a testimonial from citizens that there are more equipment in the Nairobi County hospitals and facilities before 2022. So I really can only say that, but this is very good.
Thank you. Thank you. We will go to the matter of cancer because this is a listening session. Chair of Council, when we signed the intergovernmental partnership agreement, we informed counties, and we actually worked with them on the list of equipment available under that program. And it was our expectation that every county will request the equipment which they think will assist them in delivery of service. Is there anything we can do more, Chair, to persuade, to get counties to onboard the equipment? Because I think we had only one county who had not signed the IPA agreement, that was Kiambu County. I'm told last week they have now signed. So there is no reason why every facility in Kenya should not get at least the minimum equipment so long as they have the number of patients that will justify the installation of those equipment. Do you want to say something, Chair?
I think Nairobi Governor might also want to say something. Your Excellency, with respect to the NESP, the National Equipment Support Program, we have intergovernmental agreements between individual counties and the ministry. These can also be amended with respect to what is ordered. If a county that had signed up for 5, say, equipments realizes that they need more, nothing stops them from signing an addendum to request more. And I know in my county, the more we have upgraded facilities, we have actually increased that request. And for a place like Nairobi, I'm sure the governor is going to speak, where traffic of patients is not a problem, there's no reason why, for instance, Nairobi cannot have more facilities with more equipment. The cancer centers have been more regional, save for places like Nairobi. In the rest of the country, they have been at the, what we used to call the general hospitals at the provincial level. But now there is a lot more counties. By the last count, at least 28 counties now have a level 5. Initially, level 5s were only at the provincial headquarters. I would now expect, Your Excellency, each of these level 5s to set up cancer centers and to ask for equipment through NESP so that we can further decentralize cancer treatment, Your Excellency. Thank you.
Thank you very much. Governor of Nairobi, something has been said about Mbagathi, but I know for a fact that Nairobi County is among the counties that we have supplied quite a bit of equipment. Governor?
Thank you. Thank you very much, Your Excellency. And thank you, Crispinas Shikuku. All our facilities have equipment. But what we want to raise, Your Excellency, is, and I'm very happy about this very candid discussion, where you have provided medicine, we have provided medicine as counties. Nairobi Hospital, like Mbagathi, had X-ray even before the NEST program. It's a big hospital. We need to sort out what we call the weakest link. And it's a problem across the country. Your Excellency, let me start with an example. The time I went to Tasia, Kwandege, level 4. And I knew that we had just supplied medicine the day before. When I was leaving, a young man, you know, normally they comes and says, Governor, nimekuwa hapa jana, dawa nimeambiwa hakuna. So I said, no, I know those medicine. Give me that list. When you look at what has been asked for, and I forced the opening of the store, it was there. But somebody told him, hakuna dawa, enda kwa ile chemist across the road, because either they own that chemist or they're getting a cut from that chemist. Mara mingi, like today, there's no hospital that should say it has no medicine, for sure. But many times, that weak link is the human link of some unscrupulous people, and we've taken many for disciplinary, and I know my colleagues have gone through the same, who will tell a mwananchi that the machine is not working. I know for a fact Mbagathi has functioning X-ray and all that equipment, including from NESP, all our, I think 45 or so facilities, all level 5 and 4s have been stocked. But how we sort out the place where you're told the machine is not working, because the person telling you that is getting a cut from that private facility for referring people to that facility. Now, there are options we have, Your Excellency. One, we can have a helpline, where if mwananchi ukiambiwa hakuna dawa, tuambie, nimeambiwa hakuna dawa kwa hospitali hii na huyu. Nimeambiwa mashine haifanyi, nimeambiwa kwa hospitali hii na huyu. If you can work with the DHA for that, then we can isolate the individuals, because, Your Excellency, you can set systems, you've set. Equipment we have put. Machines ziko. Dawa tumeweka. That weakest last link, which is in major part, and many of our health professionals are very good. But there are few too, si ni kweli? Ama nasema story yangu. There are few who, because of corruption, which is what we must deal with, anajua akirifa Luton atasema nimetuma Shikuku. If Shikuku comes and pays 5,000, 2,000 ni yake ama 3,000. Your Excellency, that is the problem. But in terms of equipment, we have them in all our facilities, Your Excellency.
Thank you very much, Governor. And I think it is a point of feedback from what Shikuku has said, that we have a challenge that we need to sort out. And that challenge we are going to sort out if citizens also help us. So I think what Governor Sakaja is saying is, if you go to a facility and, like, for example, what Shikuku was saying, Mbagathi is a public facility. He was referred to a private facility to undertake a certain procedure, because whoever referred him, because I know Mbagathi, Mbagathi cannot be among the hospitals without an ICT machine or X-ray machine for that matter. But because that reference benefits somebody in some way, we should, therefore, with the assistance of DHA, be able to work with citizens. If they go to a facility and in the facility they are told either this equipment is not there, go to the next, or this medicine is not here, go to the next, they should be able to verify. This is homework for us. This is feedback for Mercy and for Anthony and the PS and Minister, for us to go and figure it out and work with the counties to make sure we get rid of that mischief. So thank you very much, Kuku, for that. Now, the second one is Wanjiru. Wanjiru has very emotionally talked about cancer and the support we are giving them. I remember very well the MOU that Duale has referred to when we were negotiating with the manufacturers to bring the price of that particular cancer medicine from 135,000 to 40,000. Because our argument was, as government, we have a pool of patients. We need to benefit from economies of scale. And they agreed to bring the price down substantially, actually to a third. There is a catalog of more equipment. Because of where we are today, and this is important for Wanjiru and all of us to know, that there is power in us negotiating as a government. It is the reason why we agreed with the counties that instead of every county going to negotiate with suppliers on their own, let us pull together. We will provide leadership so that we negotiate as a block. That way, we have greater power of negotiation. So, to the point of Wanjiru, we've managed to do with one company, Pfizer. I met the president of Pfizer once. I'm doing another appointment with him because quite a substantial part of the medicine that we are using comes from Pfizer. And our engagement with Pfizer now is that they will not be supplying our facilities individually. They will be supplying us collectively. And that is the point why Duale is saying we are going to engage them this time round so that we can negotiate the prices the same way we negotiated the prices for Roche and all the others. So to your point, Wanjiru, we have understood your feedback. We're doing something about it to make sure that we bring those other prices down. But there is one more thing that Wanjiru has said which we have to answer. Wanjiru has said that there is another 1,000 that has become 1,500. And I think she is saying that it is not covered by our SHA. What do we have to say to that? Somebody help me, whether PS or who? Because, yeah?
Yeah, Your Excellency, I think the CEO and Dr. Masi can answer that.
The CEO
of Kenyatta National Hospital and also SHA.
Okay, so Masi,
Thank you, Your Excellency. As I hand over to Dr. Lesiampe, it is correct, Wanjiru, that you do have to pay 1,500 for your outpatient visit. Your Excellency, what we are doing about this is, like we mentioned, at the end of October, we are reviewing a benefit package. And we are reviewing the outpatient benefit package. Many Kenyans, Your Excellency, have come to us and told us that SHA is doing well, but we need to do something at level 5 and 6 hospitals outpatient. So far we have our numbers. We'll be presenting them and defining a plan in how Wanjiru and those costs can be diminished or at least reduced at the end of October, 30th October.
Now, just to the point, this is a challenge that faces not level 2, not level 3.
Not level 4,
not
level
level
5 and 6.
So level 5 and 6.
Yes.
Because my understanding was that for level 2, level 3, and some level 5, for
Level
outpatient facility, it's covered fully by SHA.
Yes, so Your Excellency, just to clarify, level 2s, dispensaries, health centers, and level 4s, specific level 4s, it is covered by SHA on a walk-in, walk-out. But for certain level 4 facility entitlements, level 5s and 6, it's not covered. So we've had that complaint from many Kenyans. The simple procedures where you need a specialist in a level 5 who might not be in a dispensary or a health center or a level 4, but is available in KNH. So we are working it out so that we get a package and so that we're able to reimburse for that.
Very good. So again, Wanjiro, this is very good feedback. We are working on a benefits package for SHA. We had an initial one because we also wanted to be sure that we don't say we are going to pay for so much, and yet we had not had an experience of whether we would be able to pay or not. With the benefit of a year and a half of working with the benefit package that was there, we are now ready for a review on areas that citizens like you, Wanjiro, has come back to us and say, there is this pain point on my visit for cancer treatment. I do not know whether there is any added value the CEO of Kenyatta Ken. I think it has been answered effectively by Mercy, because that's the truth, right? Lesiambe, do you want to say something? Continue.
Thank you very much, Your Excellency. I don't think I need to add anything. We are going to see how by the end of October that this package can be reviewed so that we can assist some of these patients. These cancer patients go through very, very difficult times, and indeed that's why we have gone ahead at Kenyatta National Hospital to introduce a golf cart. In fact, we have 2 golf carts at Kenyatta National Hospital, which receives these patients at the bus stages and indeed take them to the cancer center. Those who go through chemotherapy, some of them after that procedure are usually very weak, they are fragile, and then we take them back to the bus stage. In fact, including the KMTC bus stages. We also use the same golf carts, which is actually does not use fuel, is actually electrical, does not cost us anything, and we navigate them through all the different areas of the hospital. So, Your Excellency, we take this very seriously, and therefore we're going to see how best we can review to make these people comfortable. Thank you, sir.
Thank you very much. I think we've gotten some useful feedback from those 2 great Kenyans. Please proceed.
Thank you, Your Excellency. Because of what was said of the referrals, if the facility, the public facility is working and a patient is referred out, chances are it's a healthcare worker that is doing the referral. So I think we bring in the healthcare workers now to give their comments also on that particular issue and any other that they may have. Any healthcare worker in the room? There's a hand up there.
Thank you very much, Your Excellency, and the government officials here. So first of all, to respond to my brother and my boss, Honorable Sakaja, it's true. I'm Dr. Dennis Miskela, the Deputy SG for KMPDO, the Doctors Union. It's true that we come from Kenya. Even these healthcare workers are Kenyans. So we know we come with our weaknesses, that in this sack of healthcare workers, there are rotten apples. And as KMPD, we never shy or defend when healthcare workers make mistakes. We also fall sick. So we know that sometimes that motivation to get that extra money through all those bad ways are there. But then again, as healthcare workers, we will also not sometimes allow ourselves with the punching bag that when there's no drug, wameiba madawa. When the machine is broken down, wanatuma watu nje kupata hizo pesa. Sometimes genuinely those equipment break down. Sometimes genuinely those drugs run out. So let us not punch the healthcare worker. They really go through so much to help. But what I can say that, please, can we have a proper feedback mechanism where the citizens themselves can report Because even this debate, Your Excellency, about SHA not working, it's not because SHA is not working. It's because somebody has paid for SHA, but when they go, apart from the consultation fee, they have to buy drugs outside, do ultrasound outside. They get frustrated. So what do we do instead? Why can't we have a setup where the governors can promise this summit that drugs will always be available? Not every time you see a lorry bringing cartons, they're bringing the drugs that we asked for. If we could ensure that when a patient walks in through the hospital, and I'm glad that DHA has put that system, that when you walk in to when you walk out, you don't pay for anything or buy anything outside. But to expect citizens to come and pay for SHA, then everything else they buy from outside is a problem. But as I move to something else, that right now the healthcare worker is the most demotivated cog in UHC. Why do I say so? Because on the pillars of UHC, there are certain things. Financing is one of them, and SHA is doing a pretty decent job on that, I won't lie. We have negotiated the US government deal funding around the HIV and TB. Perfect. Financing, we are doing a good job. On the issues of KEMSA reforms, 80%, 90% fill rate, perfect. We are doing a good job on that. Infrastructure right now in this country, within 5 kilometers, there's a hospital. And we just saw a deal of 13 hospitals, 300 beds being done in almost 13 counties. A decent job. ICT and record keeping, good job digitization. The biggest challenge that we must face is the human resources of healthcare. As we sit here, 33 counties have not paid salaries. That's a fact. And they have to pay rent still and go to work with fuel. As we speak here, we have healthcare workers who on the 9th of every month can't access care because governors have not sent money to SHA. SHA has locked them out. So you offer services that you can't get yourself. As we sit here, people are on strike because certain counties, after Ministry of Health availed 8.6 billion to absorb UHC workers, the counties refuse to take them. So we must discuss. Yes. We must discuss as a country, and I really read your manifesto back to back. You say that you have felt the pain of the healthcare worker, and you promise to be a neutral arbiter without compromising devolution. And this beyond 2030 discussion, we must let Kenyans decide, are they happy with how health is being run in this devolved system or not? We are not fighting devolution. We are not fighting devolution. But why can't we let primary healthcare, level 1, 2, 3, be run by the counties? Then the complex, expensive 4, 5, 6 be run by the Ministry of Health. So that if the counties fail, then the 4, 5, 6 is working. If the 4, 5, 6 fail, then the 1, 2, 3 is working. To give Kenyans a reprieve. That's all that we're asking for. Make care for us, the healthcare workers, so that we can care for the patients too. Thank you.
Thank you. Thank you. Thank you very much, Dr. Miskela. Allow me to have a nurse. A nurse.
Okay, maybe we can listen to a nurse and then we can respond to Dennis because he has raised a very fundamental issue by way of feedback.
We have a nurse on the side.
Your Excellency, to protocol observed. I want to begin by saying that, Your Excellency, if there is something you did in this country that will always remember you, is to bring that man in the Ministry of Health. That Eden Twale to the Ministry of Health. And he has brought up a team that is actually working. Plus his PS, Uma Oluga, PS, the most smiling and the door is always open. Mary Muthoni, very welcoming and workaholic. And even Director General, Dr. Moth, and the entire team at the Ministry of Health. Your Excellency, these people are working today. Be as it is, Your Excellency. We can say we have, first I want to admit, because I must speak with a clean hand, I was one of the serious critique of SHA when it came up. And you know, you used to ask me, it is you who brought SHA because it is us that formed this government. Our issue was not about the services to be provided. Our issue, I was being pushed by the people I was leading. They were saying 2.7 was high. But I can admit to you, Your Excellency, that SHA works. Every month, I spend about 100,000 shillings supporting my people in my constituents. I pay between 6,000 and 12,000 every month. Everyone telling me I'm sick, I say, have you registered SHA? No, I cannot pay your hospital bill. Go, get assessed, send me the assessment, then I pay, you go get treated. It is working. Only that we have a few people who are very poor, they can't afford. You assess, somebody tells you, I have niko na nyumba ya mapati, kumbe the husband built a house and he died. So they give you pay 8,000, yet you cannot afford that. Maybe that's the area that may want to be revised. Your Excellency, I want to thank the Minister of Health. We have had problems, as my colleague said here yesterday. Every year we have been having problems at Minister of Health internship. We fight, we destroy things, the Minister of Health. There is one particular year where we broke things, the Minister of Health, and the interns were surcharged. Today, as we are talking, under the leadership of your able CS, Honorable Eden Twale, there is no breakage, there is no mandamano on internship. That disease has been cured. Secondly, Your Excellency, the issue of universal health coverage, which you and your brother, former president, employed during COVID-19. Through his guiding and support and working with Parliament and all people responsible for revenue allocation, 8.6 billion was allocated for absorption of UHC staff into permanent and pensionable. But as we speak today, nurses in this country are on strike because the county government have refused to absorb these UHC staff. It is our prayer, Your Excellency, that national referral health facilities have acute shortage of nurses and other healthcare workers. Since you have the money, why can't the Minister of Health just take these nurses and other health workers to the national health facilities? Your Excellency, we can talk about medical products and technology, health information system. Of course, the health information system has worked very well. You know, that's why yesterday you said that Kinamugos have been removed from the system. I will want to say, under that health technology, health management system, they should be linked to the medicines and even equipment, so that if Governor Sakaja has supplied medicine to Hospital A, there is somebody somewhere who is in charge of looking at the system and knowing that this medicine is in stock. So that if a client goes and is told this medicine is not there, and he calls that number you want to establish, a person who is not in that hospital will be able to call that hospital and say, our system shows this medicine is in stock. Why are you not giving out to the public, the patients? For us as nurses, we are happy because, Your Excellency, our services we don't refer. Nursing services we cannot tell you go and get it outside. We will give it because we always have it. So we may not be actually affected by that. Your Excellency, a demotivated workforce, a workforce that has not been paid, cannot deliver services. As we talk today, yesterday, Your Excellency, you said all the county government received their share of revenue for the last financial year, 100%. County governments today, Your Excellency, have not paid statutory deduction and third-party deductions. They have not paid loans. They have not paid pensions. Some have not paid loans in the last financial year. As we speak today, August is coming to an end. Health workers have not been paid salary for July. They have not been paid salary for August, will end next week. How do you expect these health workers to go to work, to feed their children, to pay rent? You are embarrassing health workers in this country. If you are a health worker or a public servant, and you have been paid salary, and you don't pay for your rent, and your landlord throws you out, Your Excellency, human resource policy requires that you are disciplined, because you are embarrassing the employer, who is government. Now, since we are the ones being embarrassed, what do we do? Can we sack the employer? The only weapon given to us by the Constitution of Kenya under Article 41 is to go on strike. So we are asking, we open a conversation. Are we ready as Kenyans to continue having a healthcare system that is very critical in the hands of devolved system, where only 9 counties, Your Excellency, in this country have had their budget passed up to now? 14 have never submitted their budgets. 24 have had their budget rejected. Are Kenyans ready to have the health human resource with these administrators who can't even have their budget passed, who can't even afford their budgets? This is a conversation that we need to open.
Thank you. Thank you very much.
Your Excellency, the last one. I cannot sit with before saying this. I'll be lynched by members. I'll be lynched. Your Excellency, in 2017, you and President Uhuru Kenyatta gave nurses a return to work formula, where you improved our terms and conditions of service. From that time up to now, that return to work formula of 2017, Your Excellency, has never been implemented. It has been a cause for 4 strikes, including the one that's going on right now. I know you have goodwill, and you mean goodwill for this country. Through your goodwill, I'm requesting you to ask the chair of the Council of Governors to sit down with us on Friday, have a solution. And SRC should be on board. Because in 2017, we had that CBA, it was taken to SRC rejected. And today, even if we sit with Council of Governors and agree, and SRC rejects, the strike will still continue. So I'm requesting you, I know you mean goodwill for people, talk to the Council of Governors, SRC, so that we sit on Friday, because we have a meeting on Friday, we complete and send our people to go back and work. Thank you, Your Excellency.
Thank you. Do we have any other representative of healthcare workers?
Any clinical officer?
Okay.
He's up there.
Proceed.
Proceed.
Yes, and I'm very excited, Your Excellency, to be here today. I think the other time we met, Your Excellency, before you became president in Catholic University, I'm the one who gave you the memoranda on behalf of my good friends from the unions. And we have the other unions for public health and the other unions within the health sector with us here today. Your Excellency, there is something that you promised, and I remember you said that we keep the photos, so that in case you forget, we remind you with the photos. And Your Excellency, I think now I'll have to delete it. I was keeping it, but I never actually expected that we would have this forum. And you know, this is the first time we are having the head of state seated with us to discuss the matters health. We have been, as the unions for healthcare workers, even from the time our peers, Dr. Oluga, was a unionist like myself, Your Excellency, we were asking for health to be elevated to be a national agenda, and you have done that. And you promised when we met, you said that you are going to push for bold and deliberate reforms, and I'm happy that today, even those who are critical, and Your Excellency, I was one person who was critical at the start. One thing we agree on, they are bold and deliberate reforms. Maybe the other things that we are discussing is the implementation of the same. But where we are now, and you'll note that now the criticism has gone down, is because we have seen that it's working. I want to pick it from where my brother Ms. Keller and Seth Panyako have left. And sorry, I forgot to introduce myself. I'm Peterson Washira, the National Chair, Kenya Union of Clinical Officers. There is an opportunity within the Constitution, even without having to reverse ourselves to the national government. Under Article 189, the one that has been used to have cooperation agreement between counties and national government, it also provides that we can actually have joint authorities, either under the 47 counties or the 47 counties with the national government. And because what we are looking for is a unified system to manage healthcare workers, so that we have uniform standards across the board, for us, Your Excellency, we see a quick opportunity that if you can be able, through the Intergovernmental Coordinating Summit, deliberate under Article 189, it is actually possible to have a joint authority to be able to manage the health workers across the 47 counties under one authority. And Your Excellency, I must thank you because you inaugurated the KHRAC, the Kenya Health Human Resource Advisory Council. Since 2017, when the Health Act was actually enacted, this very important body that looks at the healthcare workers' welfare and the many things that are taking us on strike was very dormant, did not even have a board. But you took the step and you put it in place. And now we have an opportunity to be able within that system to provide some of the solutions that are needed for the same. So Your Excellency, for us, because you promised that you are going to be an arbiter, what we request is that you assist us so that we can have a joint authority. Within this joint authority and within the mandate of the KHRAC, we can be able to bring our specialists from the counties to that authority so that they can be available across all the counties, because the Health Act 2017 provides that our specialists are supposed to be a national asset. And that means that they should be available across the country. But with the current setting, that is impossible. If we have an authority, then they will be under that authority and can be deployed across the board. Lastly, Your Excellency, it is not only nurses who are on strike. We also have clinical officers, public health officers, and all the other workers other than the doctors. And especially the case of clinical officers is much easier because we had already agreed on a CBA, but there are some counties that have taken long to sign. We were supposed to sign on 2nd of February, and there was an invite from the Council of Governors. But as we sit here, only 16 counties have actually signed. We don't understand why the others have not signed. And it's something that, Your Excellency, if you can be able to mediate, we can be able to conclude very fast. Thank you, Your Excellency.
Thank you, Peterson. Now, that's quite a handful of manenos, but I think it's very good feedback. Let's begin, and I agree that machines, computers, medical commodities are all good. But without the personnel, they remain items. And they cannot, they cannot amount to service. For it to amount to service, people must be there. At the heart of health delivery is the health workers. And let me say the following. Peterson has put me squarely on what I said when we had the health summit before the last election. And I'm very happy to see you, Peterson. We have not met since that time. The problem, you forgot to come with the photographs. and I already gave you the leave. I told you, keep these photographs so that in case I forget, remind me, tell Mr. Boss tulikubaliana hii. Unaona hii picha. But I guess you also agree that 80-90% of the things we agreed at the Catholic University, we have implemented. There are some outstanding issues, among them the issue you have raised, and I'm going to see how we can navigate so that we can take this forward. So human resource is a critical part, possibly the most critical part of the delivery of health as a service. To give it to the counties, and when I said I'm going to be an arbiter, you can confirm. And the chair of the Council of Governors here and the governors can confirm that the relationship between the national government and the county governments is way better than it has ever been, because I deliberately chose to work with the counties, to engage in dialogue, and I must also say the counties have been very understanding. Whether it is the payment of CHPs, we've done it together. Whether it is the passing of the laws, they were always in the committees. Whether it is the equipment, the National Equipment Service, we have an intergovernmental partnership agreement. And everything else, we have worked together. Now, up to that point, we are good. You have raised, Dennis and my good friend Seth there have raised issues that I'm sure the council will want to respond, because this is not a place for judgment. This is a place for feedback, so that we're encouraged for the things we are doing right, and we are pointed out the things that are not going on in the right direction so that we can improve. It is true what I said yesterday, and the chair of the council can confirm that we have transferred all the resources for last year. We never crossed with any shilling belonging to counties. And the money for July was already paid. The chair explained yesterday the reasons why some counties have not paid the July salaries. But what these good people, representative of health workers, Dennis and Seth, are saying is also correct. You know, a whole, if today is the 19th, right? 19th of August, and salaries of July have not been paid, there is a problem, you know. So we need to tidy up that, because otherwise we demotivate the most critical aspect of our health delivery. I agree with you, and if there is anything that the national government can do to support the counties on that matter, we are willing to go out of our way to support the counties so that that matter can be sorted out. The next issue is the issue you have raised on deductions, and that by the 9th, when SHA says that you haven't paid and therefore you cannot get service, I thought we created a bridge. I thought we, Mercy, you know, because it is not right that we don't provide service because an employer has not remitted the money, which they are going to remit anyway, you know? So I think that we had that conversation. I don't know whether Mwai or somebody or yes.
I'm being told to do it, Your Excellency, so because it's hot. Your Excellency, yes, we did have that conversation, and we agreed to move from the 9th to the 25th. We just need to tie up an agreement with Treasury and then be able to work that round. So we haven't implemented it yet, but you did initiate those discussions and give us the instructions that we sit with Treasury and move from the 9th to the 25th, at which date Treasury had committed that all monies would be with the counties and we wouldn't run into this problem. So it is on us, Your Excellency, we will need to implement that.
Yes, Adam. Your Excellency, this is a matter that we have discussed a number of times. That healthcare workers who are treating Kenyans on the 9th themselves are locked out. And when we were at the summit, I think why we kept is that, and the chairman was there at the summit in December, we found out that the majority of the counties were committed to paying before the 9th. Wajir is one of them that has been paying before the 9th. I think what we are not discussing here is the flow during the transition of the two financial years. But Treasury have been dodgy. We just need to do an MOU with the National Treasury, because they're the ones who pay both the national government and they pay the county governments. At times even we have a problem with our own civil servants, the chief contribution. So I think this is a matter that ourselves and the chair can now get just a final MOU commitment with the National Treasury, and we should not discuss it anymore. I think the healthcare workers, you can assure them of that commitment in the next 2 weeks.
All right. So let me tell the representatives of our healthcare workforce that this is feedback that had come to me, and I had already given direction on what we should do, because it is not correct that a healthcare worker is providing a service to others which they themselves cannot benefit from. It's a contradiction. And secondly, this is a healthcare worker who has a contract. They are not about to run away in between the month. So whether it is the 9th or the 20th or whatever, they will pay finally. So to the good people, Dennis and Seth and Peterson, that is good feedback. I will deal with it. And we will make sure that no health worker is locked out on account of the county having not remitted their deductions, and then we will see how to work this out with the counties, right? Dennis, this is not a demonstration. Then the third issue which has been raised, and I will give you, Chair, I will give you time to respond, and also Abdul Samad. The third issue, by way of feedback that has come to us, is the outstanding CBA agreements with nurses and with the other health care workers, and the need for us to bring on board the Salaries and Remuneration Commission. The Salaries and Remuneration Commission, as we all know, is an independent institution, but we will socialize them to the need for us to have an agreement with the Council of Governors and with the health workers. So again, that is some homework for me. I will make sure that the SRC comes on board. I'm sure the Council of Governors will also do their bit, and they are here, they will speak for themselves. Finally, is on the issue of the staff, former staff of UHC. We did make available resources to transition these good people to permanent and pensionable. We made the resources available. We just have a minor issue between us and the counties, which we should be able, I think, Chair, ladies and gentlemen, let us sort this out. And let's give ourselves a maximum of a week and sort this out. I have given options. I have said, if the counties have a problem absorbing these workers, the national government will absorb them. So it is up to us to, but I would really, because I know the risk of us absorbing them as a national government, because it will undermine service at the counties, because we will basically be transferring staff from our county facilities to national government facilities, and yet at the county facilities they are providing service to Kenyans. In any case, we don't have national government Kenyans and county government Kenyans. We only have Kenyans. Yeah? So I think this is something that I undertake that between me and my good brothers and sisters at the county, we will look at it. Chair, and then Abdul Samad.
Your Excellency, let me have a first go at it, and then my colleagues will back me up. Your Excellency, we are good friends with these union people because we spend a lot of time with them as governors navigating these matters. But the things said here should not take away from what counties have been able to achieve in this sector. This morning when we were in the other hall there, we took cognizance of the fact that in 2013, in the run-up to the first elections under the devolved system of government, we had about 900 doctors in district hospitals. Today we're talking of close to 5,000 doctors in county hospitals. Your Excellency. Your Excellency, you very well know that I'm a returnee governor. I served in the first term. I was out for 5 years and I'm now here. I inherited Wajir with one doctor. I think that one doctor is here. Dr. Somo, I don't know whether he's here. He was in the hall today. Today we have over 70 doctors, of which over 20 are specialists. I remember advertising for a consultant 3 times, and no Kenyan was interested to come and work in Wajir. And I went and sat in the office of General Kaiseri, and I said, you need to give this Ethiopian doctor a work permit because he's a consultant. I can't find a Kenyan consultant. And that Ethiopian doctor was the only consultant in my county for years until we sent our own doctors to go and specialize and become consultants. He died in a road accident. He's called Dr. Janai. People know him in the medical profession. So the things people say here about counties and devolution are not, it's not what it is, Your Excellency. Your Excellency, there are things, I think this reaction, first of all, emanated from what Governor Sakaja said about people being sent to private facilities, and I'll respond to that last. It is true, Your Excellency, and I said it here last night. Since you came into office, we have not had instances of crossing over and merging finances of one fiscal to the other. It was very ordinary in the past for June allocation to be paid in July or in August. We have our June money. We have our July disbursement. But there is another matter, Your Excellency, of the treatment by independent officers and commissions, and especially the matter of COB with respect to county government. We have asked for an IBEC, which His Excellency the Deputy President chairs, and IBEC will happen on Monday. This will be one of the issues that will be discussed. As for those counties that are yet to submit a budget, Your Excellency, those are the vagaries of democracy. Budgets are drawn by the executive, but they're approved by the county assemblies. And sometimes they take their time. And they sometimes, we don't meet certain deadlines. But the financial architecture has taken care of that. Even when a county has not passed a budget, the law, PFM Act, allows that county to access 50% of the last year's budget within the first 6 months. So those are things that we will navigate. This particular incident here of 33 counties not being able to pay salaries, as I said last night, is just as a result of the fiscal year transition from one to the other. Once all these budgets are approved and uploaded into IFMIS, it happens once a year, so it will not be an issue. Most of the time in the past, it has been an issue of disbursement and releases of money. In this particular case, Treasury has disbursed. We are having crossover issues, which we will deal with on Monday with COB and at IBEC. Your Excellency, on the issue of CBS, as far as I'm concerned, Your Excellency, the only active issue, strike, which is not in all the counties. Nurses are not striking in my county, for instance. We have talked to them, and we are doing their promotions. We have promoted most of them. They have no issue, they are at work. But in some of the counties, I know, nurses are striking. The CBA that they're asking us to enforce today, Your Excellency, and I can easily provide a copy to you, was signed in 2017. 2017. And when they came to see me, I also blamed their leadership. I said the clinicians came and formed a union after this CBA, and they still had their matters largely sorted out. If there are counties that have not signed, because we have already made that commitment at COG level, that's an issue you don't have to call a strike for. You just need to speak to me and tell me which counties. But, Your Excellency, this CBA of 2017, I asked the union leaders, how many chairs of council have been here? President Ruto was not even the president then. How many ministers of health have been here? You are raising it now. But the amount we're asking for is what was to have increased from 2017 to date, when a shilling has not increased. So we met as a leadership and we made a very good offer. And we also told them how we will move to where we ought to be. Given that nothing has moved, not a dime, from 2017 to date, and they are to come back to us on the offer that we made to them. As chair of council, I am determined to ensure that we have an understanding with the nurses. But I want to say here now that the CBA, which they are asking me to effect, was signed in 2017, and nothing had moved on it. Your Excellency, the question of whether health should be managed at national and county level is a constitutional matter. But I just want to give you an analogy, Your Excellency, because there's another elephant in the room, and that's the one of supervision. And Masakela is my good friend. Your Excellency, every time, because no sitting president of this country understands Kenya more than you do, because no one visits the periphery and every county more than you do. Whenever there is an attack of some sort, a bandit attack, an opportunistic attack by Al-Shabaab in a place like Mandera, Wajir, by virtue of proximity to the boundary, teachers, some of whom are 300 kilometers from where the incident happened, come and demonstrate in front of TSC to be demanding to be taken out of the region. Yet the incident happened where? 300 kilometers. 300 kilometers between here and Busia. So it's something happening here, and somebody in Busia asking to be transferred out of Busia because of insecurity. Those are the shenanigans we will be dealing with if we go the way Masakela wants us to go. Counties have no problem managing healthcare. 5 or 6 of His Excellency's cabinet secretaries were governors managing counties. There is not a single governor today who cannot manage a docket at national level if he gets the opportunity from His Excellency the President. That is not the problem. The problem is systemic issues that we have to deal with. The approval of funding by COB and the like. Your Excellency, coming to the last matter, which is the matter of conflict of interest. Conflict of interest. And I know this is a very, very, and should I say, sensitive matter. Your Excellency, the problem you have in this country, which is a good problem, is that you are running a very democratic country. And democracy limits your hands in dealing with certain things, just the way it also limits my hands as a governor. We have a situation in our counties where doctors who have been trained with government money, some of whom are consultants that counties have been paying their salaries, and sometimes they're away for as many as 5 years. I have one who was away for 9 years. He's specialized and specialized further. And then COVID happened, he stayed longer. When they come, what do? They set up specialist clinics next to our hospitals. And they want to use the government salary as a retainer, as a safety net, but earn more money running their private practice. And these are the issues that we're having with our doctors. And I do want to raise it here, but we're having a frank conversation. Those are the issues that we need to deal with. If you are in public service, there's a clip that's going around the last 2 days. I don't know whether whether you have seen the pediatrician in Turkana. A Kenyan, I don't know whether that was on national TV, saying he met this pediatrician in Turkana who does 4 days a month in Turkana. He does 4 days a month. Your Excellency, is it fair for the Kenyan taxpayer to pay a consultant 400,000, 500,000, and there are consultants who earn 700,000? I know consultants who earn more than deputy governors, Your Excellency, and I can provide you with this data, to work for 4 days a month. I think those are the things we need to discuss with. Having said that, Your Excellency, I will make an effort as chair of council to even get into an arrangement for the purpose of salaries so that we allow counties that are having challenges paying salaries to also have a soft arrangement like some of us do with Kenya Commercial Bank so that they pay salaries on time. I can face Panyako because I have paid my salary, I have paid my chief, I never delay in doing it, but you cannot come and generalize things here. I thank you, Your Excellency.
Thank you very much, Governor. Do you wish to say something?
Samad, please help me.
The chair of Committee of Council of Governors, briefly.
I think we know each other with the union leaders on first-name basis. And I think the number of calls that I get from them in communication is probably more than what I discuss with you. I want to start, an example is Peterson, Kenya Union of Clinical Officers. The last conversation I had with Peterson was actually just yesterday, Your Excellency. And it was myself, together with Governor Sang, that actually negotiated the return to work formula. There's some things, Your Excellency, that are beyond us. SRC is a constitutional body. I have to go out of my way, and the Secretariat, the able Secretariat of the Council of Governors have to go out of their way because we need a no objection from SRC. I signed, other counties have been able to sign, others are in the process of being able to sign. But even after that goodwill, you're still being told that, and I actually had to call him and tell him there's a level of goodness that we can also be able to do, because if we have signed and have done our part, there's really so much that we can be able to do. The doctors, in fact, I know that I'm meeting them on Thursday, actually, Your Excellency, which is tomorrow. is it tomorrow? Yeah, on Thursday, I'll be meeting the doctors. Some of the issues that we've been able to do and work on. Today, we're implementing a CBA, including paying salary arrears, including, we actually had to personally call the head of the Ministry of Public Service for purpose of getting a special code for ensuring that we pay the salary adjustments and so forth. The issue of nurses, Your Excellency. Prior to the strike being in place, the Council of Governors had already put a team and they were already negotiating. Negotiations had already started. And even without anything else, the nurses opted that, yes, they want to go on strike. I've heard the issues that have, you know, and it is okay. It is okay because of positions that we hold sometimes, it is important for unions to be more tough on counties like ours. Because of the fact that maybe we speak on behalf of the other governors. But I, like the governor of Wajir, I think probably because of this transition, for the first time, I delayed salaries by 2 days or 3 days. I have no debt with any single employee in the county government, including statutory deductions and everything else. The issue that we're trying to make sure that it does not happen, you need to ask yourself, Your Excellency, what were the conditions that made a CBA to be signed in 2017 that every government that has been able to come through has not been able to do a CBA like that? When you sign a CBA, when you're in a position that you're under duress, because that CBA was signed on an election year. That CBA held people at ransom. Allow me, you know, and it is the reason why, Your Excellency, I sat down with the two gentlemen at the council offices and we gave them an offer. And we said, this is our offer. The least that would have happened is we're coming back now, even as we speak right now. There are so many who have gone and broken court orders because of the fact that there's actually a court case that they're actually meant to return. Because when you speak to someone and you're holding a gun on their head, you're dictating, you're not speaking. You speak under equal terms, and if we've shown that level that we want to be able to speak, the same way I've been able to speak to the Kenya Union of Clinical Officers, the same way I've been able to speak to the doctors, we were able to sort out strikes and we were able to amicably solve issues to do with many other cadres that are out there. And I think, Your Excellency, amongst the things that are being discussed at IBEC on Monday, one of them is the issue you were talking about on SHA, that if a county has not been able to pay, what happens in a scenario like that. It is something that is being resolved on Monday as we speak in IBEC. The other issue that is also being talked about, I know Mombasa is not one of them, but it is only fair that I speak on behalf of the other governors, Your Excellency. The issue that is being discussed on Monday is also issues to do with COB. When a county like Nairobi and many other counties have not had their budgets approved, and COB opts and decide that, you know, it is just a bloating or something. But anyway, COB has decided not to do some of these other things in time. And Your Excellency, there's actually a notice that COB themselves have actually put out, that there would be a crisis on salaries. And it's not salaries just for nurses or doctors or clinical officers alone. It is nurses, including the governors and the deputy governors and the CECs and chief officers and everyone else. So, you know, for those governors, the same way we have doctors out there who decide not to go to work, which is a fact. They decide not to go to work despite the fact that they're being paid salaries. One of the reasons why you hear that SHA is not working, Your Excellency, and this is a true story on my part. I went to a hospital and someone could not be discharged because the way SHA works is, and it has been beautifully designed so that there's no fraud. The person, you know, the clinical officer or the doctor has to be able to sign them, and it is because it's geo-fenced. When that person is not there, then you're told that SHA is actually not working. But as a matter of fact, there's a person who was meant to do what they need to do when they were not there. Now, as much as there are doctors who spoil the image, if there's one or two who have decided that, you know, they're not paying statutory deductions, as my chair has said, that is the price of democracy, because someone voted for them. It does not mean that the system is wrong. It means that there's someone who did wrong. We do not know the kind of president we'll have after 2032, Your Excellency. We pray for your long life up to 2032 that we take. But what happens when we get someone else who's going to be rogue? Does it mean that the system will have to be now reversed, that things have to go back again to counties? Have we not had situations where this country has had teachers' strikes and teachers' national government? So, Your Excellency, this is a conversation, and I think the issue of human resource is something we need to sit down, and I'm glad you've actually given us a deadline and a timeline. There's a discussion we're having with CS Duale on the issue of UHC. There's no one who does not want. It is only that we do not want a situation where we can have a problem of continuity. That is all that we are saying. But we value every single healthcare worker, we value every sweeper, we value every fireman, we value every single employee who works for our county governments. And please, let's reciprocate on the same. Thank you very much, Your Excellency.
Thank you, Chair. I think that is a fairly balanced conversation from where I sit. Very balanced. I think everybody has said their piece, and very respectfully, but also very authoritatively. And I think we have agreed on a way forward on the CBS that are outstanding. What I must say is, even as we agree here, I am a very big supporter of the Salaries and Remuneration Commission. We must respect their mandate because they help us to balance between recurrent expenditure and all the other expenditures. So even as we negotiate, let us take their view into account so that we balance things out. I agree with the Council of Governors that sometimes we have challenges with the approvals from the Comptroller of Budget, and I'm happy that you have set up a meeting for Monday so that that can be ironed out and we can have the counties to discharge their responsibility as is expected of them. Let me say two final things on this matter. There is somebody who said that there is an issue about how much, I think it was Panyako who said, some people, when they go and they are being means tested, sometimes they do not get the right, testing, because maybe they said they have this, maybe the assessment was not accurate and that kind of thing. I think that's homework for us. We need to continuously sharpen the means testing instrument. That is homework for at least my office, especially Mwai and the professionals who work with me, so that we can assist the ministry to sharpen the means testing instrument. Is that correct, Mwai? Yes. I want to just promise you that we're still collecting data on making sure that when we do an assessment of a citizen on how much they pay, we must be as near accurate as possible, so that we do not burden a citizen who has a certain ability and we misjudge them to have a different ability. So that is good feedback, but already it is in our radar that we have a means testing instrument. We are still gathering data, and we are using We're trying to access data from different sources so that we can have a much more accurate means testing instrument. Let me, however, say that there are people who have means. And this is Kenya, There are people who earn more salary, they have better businesses, but you will find them complaining that they want to pay the least. When in actual fact, they should be able to pay more because the assessment that they go through says a different thing. So we must continuously not burden, and I must say this, the people who earn salary, everybody knows their salary. But there are people who make as much money doing business, but they don't want to pay as much as those who have a salary pay. They want to pay less. That is unfair. In fact, the court instructed us that we must be fair. Those who have a salary must pay. Those who don't have a salary must also pay, and they must be assessed correctly. So I think that is an area that we will keep improving as we go into the future. One final thing that was said is on the matter that Peterson raised. I think when we were in that summit, when I made commitments, I said we will find a mechanism which will bring the county governments and the national government into a place where we can discuss health, human resource issues. You remember Peterson? And that is the reason why we set up the KHRAC, right? The Advisory Council. Maybe it is not doing exactly maybe it's not very effective. I think we should find a way of making that body much more robust and active before we can explore the opportunity you have said that maybe under Article 189, I don't know whether that is possible, for us to set up something to deal with human resource. But I think the best place to start is the advisory council that we have. Let's see whether we can put some energy into that organization and see whether we can manage the human resource issues collectively as the national government and as the county governments. And I think we have agreed on the UHC staff. Within a week, myself and these good friends of mine, governors, we will agree on how these workers are going to work and move forward. We have also agreed on statutory deductions. That is my homework. That I will sort it out. We have to, because it's not right for us to deny citizens who are working access to health on account that their deductions have not been received by us, yet they have already been deducted, and they will be paid anyway. We must find a solution. With the Treasury, without Treasury, Aden Duale, please sort that out. If you need some ideas on how, look for me. I will give you some ideas. I think those are the issues. I don't know whether they are Mercy.
Thank you, Mr. President. I think we have discussed the healthcare workers quite comprehensively. Next, I'd like us to have a conversation on renal care. It's an important conversation because in there are issues of non-communicable diseases such as diabetes and hypertension that can cause, complications on renal care. The issues of dialysis, the issues of transplant, and also the immunosuppressive medications that transplant patients sometimes require. So I think we can unpack all of that and have a conversation around it. So we can start by somebody with their lived experiences on renal care. All right, you're already up. Please, the floor is yours.
Thank you, Mercy. Your Excellency, distinguished ladies and gentlemen, my name is John Gikonyo. I am the president of the Renal Patient Society of Kenya. I'm also the Vice Chair of the Non-Communicable Diseases Alliance of Kenya. I am a kidney patient myself, living with a kidney transplant. I got my kidney transplant in 2015 at the Kenyatta National Hospital. And I'm proud to say that between then and now, the good people at Kenyatta National Hospital have taken good care of me and other renal patients. And that's why I have known nothing but good health in those 11 years. Your Excellency, I represent a group of people who are considered to be the greatest beneficiaries of the Social Health Authority. And I say this because the cover we have for both dialysis and transplant is, honestly speaking, quite generous. A patient on dialysis in Kenya is covered for 2 sessions every week, each session at 10,650. If you total that for 1 year, it's 1.1 million shillings per year. Now, a lot of people would not be able to pay 1.1 million shillings to pay for 2 sessions per year. And therefore, the 7 or 10,000 people currently living on dialysis literally owe their lives to the Social Health Authority, and we don't take that for granted. The patients who are lucky and able to get a transplant like myself, we have a SHA package which covers 1.1 million. That is for pre-transplant evaluation. Then there is the transplant surgery itself. There is the donor nephrectomy, that's removing the organ from the donor. And then there is a post-transplant management. If you total up all those figures, they come to about 1.1 million shillings. And therefore, we are very grateful to the government and to SHA for this package. And we would like to encourage SHA to continue supporting us. We would like to encourage SHA to speak to us regularly, because sometimes there are challenges, particularly access challenges, that need to be ironed out so that whatever is not going on well can be sorted out. And I would like to pick a few issues. The dialysis package, like I've said, is 2 sessions. But if a patient gets admitted, if a dialysis patient gets admitted to hospital, they are only covered for 1 session. And this is a bit strange, because if you are on dialysis, you are already a patient who is unwell, but if you now need to be admitted, it means your health has deteriorated, which could probably mean you need more dialysis than the 2. Remember, international best practice recommends 3 dialysis sessions. But we only give 2 because that is what we can afford for now, and we understand that very well as patients. That we only get 2, despite recommendation of 3 dialysis sessions, we get 2 because that is what we can get for now. And I'm talking about now a patient who is getting 1 session because they have been admitted. So they will even get more sick, because if they are not able to pay for the extra one while they are in hospital, then they will not get well very soon. But what is even worse, Your Excellency, there's a condition called acute kidney injury. And this is a sudden onset of kidney failure, either from an infection, an injury, an accident, or something like that. If acute kidney injury is tackled quickly and intensive care given, which would involve, for example, 5 full days of dialysis, there is an 80% chance that the condition can be reversed, kidney function will be regained, and the patient can go home well. But now when we only allow 1 dialysis session for this patient, because they are any patient, what we are doing, I'm imagining the reason we are doing this is so that we save some money. But what we end up doing, and this is very sad, is that we are saving 50 or 60,000 at the risk now of sending this patient to full-time dialysis, for which we will need 1.1 million per year, and they will have a very bad outcome and a reduced quality of life. So these are some of the things we would like that SHA to reconsider, so that people get the care that they need at the time that they need it, because some of the access rules, unfortunately, are not fair to the patients. We have, like I've said, a post-transplant package. This is a package which supports now the medication and the clinics that we need after transplant. I would like to thank your government and SHA, because this is new. This came with SHA. We had a dialysis package and a transplant package before with NHIF, but when SHA came in, we made a plea and it was accepted. We now have pre-transplant evaluation and post-transplant care. That we attribute to your government and Social Health Authority. Again, we have some challenges with access. Some of them are from the system, particularly the DHA system. We have a very, very cumbersome system where we have to give a lot of paperwork. KNH has now gone paperless. Hata ukilipa pesa upate risiti siku hizi. Hakuna karatasi KNH. And we are happy because things have improved, things move quick. But when it comes to SHA, I have to go with 6 documents, which I have to submit, then they have to be scanned, and even the physical part of doing that and taking them through all this takes a lot of time. Sometimes the system hangs. We would like the SHA system and the DHA system to be streamlined so that we can also go as smoothly as the rest of the things. And sometimes we are forced to go home without drugs because the system hanged. And to respond to CS Duale, who mentioned about, sometimes people switching off the system so that we can pay cash. A lot of time when the system goes down, you can't even pay cash. It goes down, nothing can happen. It's a very difficult and sad situation. And people at KNH, for example, wouldn't do that. And like I have said, I've been with them for over 10 years, so I know them. They cannot switch off a system to make you pay. So whenever it happens, it's a genuine problem.
Thank you, Gikonyo.
Yeah. Let me just finish, because the President gave us a challenge to talk about beyond 2030. And I have not heard anyone talk about it. So I would like to make some asks on that. And what I would like to ask Your Excellency, and some of these things I would need to seek your personal intervention, is that we need a renal registry. We need that because we would like to make data-driven decisions around kidney disease. We do not have a registry as yet, so a lot of figures we throw around are imaginary. But before we get there, I would like to make a plea to Dr. Mercy Mwangangi and the gentleman from the DHA. I know if you go into your system, you can be able to tell us, for example, how many people accessed post-transplant medication in one period, how many people accessed dialysis. And if you can share that information with us, including with Dr. Lesiampe and her team, and his team, they would be able to make better plans. And I'll tell you why. Currently, that post-transplant package is only available at KNH and MTRH. But they cater, KNH can tell you how many people they have transplanted since they started. But they cater for people who are transplanted in other hospitals, including outside the country. So they cannot be able to predict properly today how many people will come for clinic next Tuesday if they do not have this data. And so they find themselves in problems which they are not able to solve because there is some darkness around how many patients a patient needs this service and how do we prepare for them. So we would like Your Excellency for that. We propose that this registry is domiciled at the Center for Excellence for Urology and Renal Disease Services, which we have been promised will be commissioned very soon. And I saw CS Duale inspecting that compound recently, so I know there is something in the works. And if this can be domiciled there, then we can be able to interact with that. And we will have to have, like I said, data-driven interventions and preparations. Now, I would like to bring to your attention, Your Excellency, that the Kenya Blood Tissue and Transplant Service has, for very many years, been trying to come up with a deceased organ donation program. And the reason we are doing this is because currently, if someone needs a kidney transplant, they can only get a donor from within the family. So previously, before the post-transplant cover that I've said came with SHA, a lot of people are preferring to stay on dialysis because when they're on dialysis, they don't pay anything other than the subscription. But if they do a transplant, they need to buy medication, and they feel they cannot be able to do that. Now we have some money coming our way. And the question is, why haven't we seen an uptick in people seeking transplant services? The reason is kidney disease is a family disease. So if I am still being requested to go back to my family to look for a donor, there's a high likelihood that most of them will not qualify because if it's a genetic disorder, then they are all affected. And that now keeps people on dialysis because the only exit from dialysis is a transplant. So if you cannot get it, you're stuck in dialysis. We think that your quality of life will deteriorate if you are on dialysis for more than 5 years. So the cure for that then is a deceased organ program where we can be able to take organs from our dearly departed and then we can use this for transplant. We can also relax the rule that requires me to go to the family so that now my friend or my neighbor can donate to me. The Kenya Blood Tissue and Transplant Services has been working on a framework to operationalize the law that is in the 2017 Health Act. And this process has been stuck since 2023 because of lack of funds. I would like to make a special appeal, Your Excellency, and the Honorable CS for Health. Please make sure that this effort is funded so that we can be able to finish the technical working group that was working on this is able to finish his work so that we can expand the donor pool in the country and more people will be able to exit dialysis and go for transplant.
Thank you.
Just two more. Okay.
Thank you. Let's allow others
Let me talk
feedback.
about an NCD. I would like to request that I know we're having a census in 2015. Again, looking for data. We don't know how many people are living with NCDs in the country today. I would like to make a request that during the census, the next coming census, that we put a question on NCDs so we can have some semblance of data of the people living with NCDs in the country. And finally, I would like to make a plea for meaningful involvement of people living with NCDs at the decision-making level so that we can contribute towards some of these decisions using our lived experiences, and that is the end from me. Thank you very much.
Thank you very much, Gikonyo. You have packed quite a lot of things, and I could see the President taking notes. We will address that later. Allow me to also just pick 2 or 3 more lived experiences. There was a couple, and yesterday we had a conversation on seeking care in public hospital and those who go to private hospital. Both experiences in a private or public hospitals that wanted to share that story. Oh, he's here. You can just come
Thank
here.
you, Dr. Masu.
You can just... Okay.
Thank you, Your Excellency. My name is Joseph Mutinda Kimatu. With me, I have my wife.
I'm Frida Mutindi.
Yes, we got involved in a road accident on 1st of March this year. On our way back to school, we are teachers in profession at TSC, and we were admitted in Machakos level 5, but because of logistics of surgery, I was the one who was left at Machakos level 5, and then my wife was referred to German Medical Center in Machakos. So we went through surgeries because I had a acetabular fracture at my right leg. And then my wife had a femur fracture on her right leg also. And throughout the process of treatment, I took around 3 weeks to have everything taken care of because of mild injury and also some scars you can see in my head. And, she took 1 week in German Medical Center. The bill that was there in Machakos for me, it was 224,000, and ours was 145,000. And Mwalimu comprehensive cover, which is also included in SHA, everything was catered by SHA, around 369, almost 370,000, and no single cent we paid for that service. We have also been going for the clinics and also for the checkups on MRI, CT scans, X-rays in imaging center at Machakos, and everything has been taken care of by SHA. So we are here to witness and confirm that through that deduction, Mr. President, you said yesterday that cuts across all the civil servants, we benefited fully without paying any single servant, and I'm sure every civil servant here can also confirm the same. And I have to congratulate you also, Mr. President, for being in the forefront to launch that program for emergency services. Because, for example, in our case where we got the accident, it was somewhere in the bush area, somewhere where we were going in work, and it was out of the Good Samaritan we survived in that accident. So thank you so much, Mr. President, for being the forefront to ensure that the health care in this country is working well, and we truly say we appreciate for that service. Thank you.
Thank you. Thank you very much. Mr. President, yesterday you spoke about Linda Mama, Linda Jamii, and on my corner here I can see a few moms and their babies. If there's any who would want to give the experience, kama kuna mama yeyote ambaye angependa kuzungumza, hata kama si hawa pale, kama kuna kina mama yeyote, naona kuna mmoja pale.
For me, I would like to talk on behalf of mothers with children with disability. Personally, I'm a beneficiary for Tenwek and Bethany Kids Kijabe. Those two hospitals, my son have benefited his spina bifida. He has benefited on the surgeries. The 3 surgeries that were done for him, it was around 300,000, and all of them were sorted out, both in Tenwek and both in Bethany Kids. So personally, Mr. President, I'm so concerned when it comes to early interventions for children with disability, especially when it comes to therapies. I would really ask if SHA can help us in accommodating our kids on therapies, because there is where we have a lot of challenges, Mr. President. Again, we have issues with diapers. Yes, yesterday you guys talked about diapers. Our children also need diapers, because that is where we have so many challenges. We have mothers who are still wrapping their big children with cloths because they lack diapers, and that one is like lacking hygiene when it comes to that. And again, we really like, as caregivers for children with disability, we really like if we can have a mental health rehabilitation, because we have a lot of challenges when it comes to raising children with disability. And also, I would really like to urge SHA, if they can help us in assistive devices, if assistive devices can be placed at SHA also, so that most of our parents can see on a better option when it comes to orthopedic area. And lastly, I would really like you, Mr. President, to consider our national days when we celebrate disabilities days. Like September, we'll be celebrating World Hydrocephalus Month. So if you can celebrate with us, we'll really appreciate that. Thank you.
Thank you very much. We have a team from Moyale, and I know sometimes people or Kenyans who live at the periphery have access. Okay. Aya, simama basi uzungumze kabla tuende Moyale. Ongea tu, ongea. Just raise, weka microphone. Karibu.
SHA ilinisimamia kila kitu, and my SHA was temporary SHA, and it has already expired. So pia nilikuwa nauliza if I can renew it because I'm underage.
Just hold on, eh? Can you begin? I didn't get your first part of your conversation, please.
Okay. I'm Stephanie Muya. I'm 18, and I gave birth at Mama Pumwani, January date 2, and I used temporary SHA, and it has already expired. So nilikuwa nauliza kama I can renew it, the temporary SHA, and then bado sijapata ID. Na hiyo temporary SHA bado itasimamia mtoto wangu. Ndo nilikuwa nauliza. Then, apart from SHA, I'm a dropout, and I'm a young mother. Pia ningependa unisaidie. I want to go back to school. That's all.
So, we can go?
Yes.
Okay. I thought first, okay, let's begin. Maybe we can begin with Stephanie. Yeah, Stephanie, by the way, I have a daughter called Stephanie. So, Stephanie, back to school, you will go. Yes. I want somebody to answer Stephanie about her temporary cover. You remember yesterday I said the government of Kenya is going to pay for our teen mothers. Mothers who do not have an ID, they cannot pay for themselves, and so the government of Kenya is going to pay. Mercy?
Yes, Your Excellency, you made true to your commitment. SHA does have 1 billion Kenya shillings that you've availed to be able to ensure we cover teenage mothers. And to date, we've covered about 100,000 of them through that program. And that is what Stephanie is talking about, the temporary SHA program. This program runs until the teenage mother is 18. And so it serves for any teenage mother from the age of from 13 all the way to 18. Once the mother turns 18, we expect her to get an ID and then to be able to pay into SHA. So in Stephanie's case, she's told us she's already 18 right now. She's already 18, so we need to help her to get her ID, and then now we need to find a mechanism of supporting her. But the program that we currently have, Your Excellency, has served 100,000 teenage moms in the country, fully paid up premium for them and for their family up until they turn 18. So if a mother is 14, she gets cover until the time she turns 18, together with her family. Yes.
So what do we tell Stephanie? Stephanie is now worried about herself and her child, and
yes,
I think we'll take care of her going to school.
Yes.
That becomes the Ministry of Education's assignment. We will make sure that we find a school for you, and pay for your school fees.
Your
But then, what happens to Stephanie and the child?
So, Your Excellency, because Stephanie is yet to go to school, it means she doesn't have an income, so we can enroll her in the SHA sponsorship program that you've also availed resources for.
So, does she qualify under the program we have for indigents?
Yes, she does. She does
Okay.
qualify for the indigent sponsorship program.
Okay, so Stephanie, you remember yesterday I said we have 560,000 Kenyans who we pay for. So we will make it 560,001. And Stephanie. So please include her in that program.
We shall do so, Your Excellency.
Now, I think one gentleman has been, first let me thank Mr. and Mrs. Mutinda. Thank you very much, Mr. and Mrs. Mutinda, for saying two things. That you've actually proven to us that whether it's a private hospital or a public hospital, I've kept on telling the people of Kenya this, that once you are registered in SHA, you can go to any facility, and as long as the facility is registered with SHA, then we should be able to cover your bills. And for you and your wife, you have also given me one more confirmation. I had a very candid conversation with the Teacher Service Commission and the teachers' unions, both KUPPET and NAT, and I persuaded them that they were better off in SHA than in private insurance. I think what Mr. and Mrs. Mutinda have shown is that that is actually correct, because today teachers who had access to one level 5, level 6 hospital, today they have access to all the hospitals. We've expanded cover. Teachers can go to as many facilities as are available in their locality, and we've made the cover much, much better. And congratulations, Mwalimu, and Pole for the accident. Now, we have one wonderful gentleman, Mr. Gikonyo, there. Thank you very much, Mr. Gikonyo. You are a wonderful Kenyan. You have given us so much feedback. I have written my page, and I've turned over the page to write some more on some of the feedback that you have given us. I like the fact that you agree that we have improved on the cover from what was 400,000 for transplant. It's now 1.1 million. That's correct, Mr. Gikonyo? And from what was covered in dialysis, we have enhanced the amount so you can access more facilities. And we have done many other things to make the life of people like yourself and others who are living with non-communicable diseases, their life bearable and better. You have, however, raised a couple of issues which I want us to address by way of feedback. You have raised the issue of acute situations that if we handled them differently, maybe we would have a better outcome. I don't know whether my team has any views. You know, is it something we can carry as feedback and homework for us to go and think about by way of improving the cover? Because I think the suggestion he's making is, yes, we may be making a little saving by limiting the number of dialysis. But if we dealt with it early, maybe we'll have a bit more sessions, we could actually save the kidney. Is it something that doctors can verify that that is the case? And if it is it something that we can onboard as a different approach to this, as Mr. Gikonyo said?
Thank you, Your Excellency. Yes, we actually have the head of all the kidney doctors in the room. If Dr. Wala is in the room, oh, good. Dr. Wala can confirm that acute kidney injury. He's a specialist. Please talk about it before.
Thank you very much. Thank you, Your Excellency, and thank you for this invitation. Dr. Jonathan Wala, the Chair of the Kenya Renal Association. My colleagues call me President, but now I'm in front of you. I cannot use that word. John Gikonyo is a good friend of ours, and we have worked a lot in the renal space. Acute kidney injury is an acute situation that can affect anybody, especially can affect children with severe diarrhea, can affect mothers during their pregnancy, or anybody who becomes sick. During that period of time, unfortunately, we don't have several things about the cover. The first one is about the way to do dialysis. That means there's no cover for the insertion of the catheter itself. And that's a major hindrance into entering into dialysis. The second one now is what Gikonyo has pointed out about the once-a-week cover. And that's what we want to try and see whether SHA can address that to improve the outcomes of kidney failure patients. Beyond that, there is care for that kidney patient so that we don't have anybody else coming back for chronic kidney disease and therefore a maintenance dialysis that costs a lot of money. And that's what we are looking forward to SHA addressing. Thank you.
Thank you very much.
Your Excellency, I wanted him to come in just so that as you give us that homework, we're able to be aware that these would be many, many cases, meaning they would have, and he's right, they would have a cost implication. So all the mothers, should they lose blood while pregnant, delivering, they become potential candidates of AKI. And so it's many Kenyans as opposed to the 25,000 who we currently have on continuous chronic dialysis. But we will do the homework and do the numbers with Prof. Jauko and determine what the impact would be, budget impact would be.
Thank you very much. Again, it will go into how we improve the benefit package and all that, but it has to be costed because we do not want to make a commitment that we are going to cover when the resources are not adequate. We must, for every commitment we make, we must work out the numbers and we must be able to pay for it. Otherwise, we can make this progressive. We can take it to the next level, assess it for a while, and then see what we can do. That good gentleman, Mr. Gikonyo, has also told us that we need a renal registry because he has said data is very important. Is that correct, Mr. Gikonyo? So, my good friend Anthony, it is possible for us and it is necessary. The reasoning given by Mr. Gikonyo there is to be able to effectively provide interventions, we must have a good body of data. Numbers are important. There are some people, Mr. Gikonyo, who are telling us that numbers are not important. That why are we registering people? Why are we talking about people who have been registered? Is SHA registry. You are telling us to do another registry. You know? Because you've said, what is your reasoning, Mr. Gikonyo, for the registry?
It's working. Reasoning, Your Excellency, is that we need to make data-driven interventions with evidence from the situations that we are going through.
I hope those who have arguments against our data are listening to Mr. Gikonyo. Mr. Gikonyo, you have said what your personal experience on what SHA has changed for the people who have conditions like yours.
Yes, sir.
And in your opinion, we've made very good progress.
Absolutely.
What do you tell those who are telling us we should scrap SHA?
They should pray very hard that they don't fall sick one day and they find themselves in a situation where they cannot foot their bills, and if not them, one of their relatives. Let me give an example. If someone needs dialysis suddenly, and that is 80% of all the people who need dialysis, they find out that they need dialysis one day when they collapse, and they wake up in an ICU, and they are the last to know that their kidneys failed. Why? Because kidney disease is a silent disease. It will work on your body without you knowing. You will feel some changes which you will correct with Panadol and other adjustments, but eventually your kidneys shut up. By the time you wake up in ICU, you will have received probably 4 or 5 dialysis. So you will already be in the red for 50,000 shillings, even before you have been told what is wrong with you. That is how critical it is to have a cover that can take care of you when you're in that situation.
Thank you very much, Mr. Gikonyo. Mr. Gikonyo has told us one more thing. He has told us the best way to get out of, the whole space around dialysis, because dialysis is good because it saves lives, it prolongs somebody's life, but kidney transplant would actually solve that problem in a much more fundamental way. Is that correct, Mr. Gikonyo?
Yes, sir.
So, and he says there are now restrictions on how somebody gets access. It has to be a member of their family. And he has given us suggestions by way of feedback, which is the reason why we are having this conversation anyway. We want to know from citizens, how can we do this better? He has told us that we should expand the pool of access to kidneys to non-members of the family, and possibly create a framework where we can get organs or kidneys from deceased persons in a framework that is acceptable legally and morally. Is that what you're saying?
Yes, sir, but if we had a deceased organ program, we would expand donations to beyond kidneys, because we would now be able to get other organs that are transplantable, and a human body can give up to 8 organs that can be transplanted. So it would be a wider pool where even other conditions can be supported.
Is it something that can be considered? Is it something that he tells us that there was already a conversation in that direction?
Your Excellency, as a country, we didn't have enough policy and legal framework. But after what happened in Eldoret and the whole story of organ harvesting, the committee which Dr. Wala here, not the president now, but the leader of Kenya Renal Association, was a member among many other experts. That report now is before Parliament, both the Senate and the National Assembly. There was some work we were to do as a ministry, develop the policy, the framework, and the legal instruments, which we are about to finish. Parliament is ready and waiting for us so that we present to them, so that as a country, first we have the framework, the legal, and the policy, which I will bring to Parliament and the Cabinet.
So I think we can then tell John here that what you are suggesting is already under consideration. We must, however, guard ourselves and expand the pool of how a renal patient can access a kidney to save their lives or to share with another citizen. So I think that is work in progress. The last issue that I picked from my good friend there is they need better participation in the policies that we are implementing. And I think he is just speaking to a constitutional principle. It is no longer a sterile provision of the Constitution that public participation should be part of the engagement of us going forward. And therefore, I think what he's asking for is, as you develop the policies and the legal framework that affects people like him, they must be involved. And I want to commit Bwana Kikonyo, that is going to be the case, and you will you will participate.
Thank you, sir.
There is one more good lady. Sorry, I didn't get your name. Yeah, she has told us. Sharon. Sharon has told us about children living with disability and caregivers who are supporting children living with disability. And she has recommended two things. She has said we need to look at the package that is available to children living with disability, including the caregivers. What is it that we can tell Sharon and people like her who are helping with children living with disability? And she has recommended specifically that early intervention could actually make things a lot easier for both the children and also the mothers. And that these are children who deserve, support. What do we have to tell her? Mercy, do you?
Thank you, Your Excellency. If I'll start with the good news on your instruction yesterday at night, we started work on diapers, and the proposals are underway, and we should be concluding that by the end of October. And Prof. Jaco's team has already started looking at that. On what Sharon has raised, it is another area of progression that we need to work to. A child who has spinal bifida, which is a condition where the spinal cord grows outside of the body, requires care for life. And so it means that this child requires physiotherapy, speech therapy, nutrition therapy, almost every day, if not every other day. So what we need to do and what we are going to do is do the costings of that, determine how many Kenyans would be needing that service, what again the budget impact of that is, and how SHA can finance it. But Your Excellency, there's also one more area where the Council of Governors can support us. Kenya over the years has not invested in cognitive disabilities for children. We do not even have the right specialists in place. We have very few speech therapists, very few autism doctors, very few doctors who deal with those conditions. So there's some work that the ministry together with COG needs to do in training, in building this workforce, and then also in building the facilities that come with this. But from a SHA perspective, we're going to review the package and see what we start with. Do we start with 2 sessions of speech therapy a month? While we know that you require more, it's a progressive journey.
Okay. Sharon, I think we do not have good answers for you. Let me say that. But it is good homework, This is a space that is new. It is a space that maybe was forgotten. But I agree that it is a space that we must begin to, think about, whether it is mental health. It's becoming a very serious challenge. All the other issues that have to do with disability. That is a space that maybe the ministry and us, we may need to explore more and look at what interventions we can come up with. So that people like Sharon and others who support people in that space can be attended to. Sharon, you want to say something?
Thank you so much, Mr. President. Okay, I have another one again. We have anticonvulsants. Myself, I take anticonvulsants. I'm epileptic. So these drugs are very expensive, and some of them we get them at the hospital. Yes, they're being given for free. Unfortunately, some of them are very expensive. We don't get them at the hospital. So can SHA again put us on that kitty? And my question is for my request is also for our governor, Mr. Sakaja. For many counties are doing assessment for children with disability for free. Why is it hard for Nairobi that our kids can't have the assessments can't be done for free? And if it's that difficult, can we also put it on SHA so that we may enable many parents to register their children when it comes to registration for persons with disability? I know he's asking himself which it's the National Council, the card for the National Council for Persons with Disability. Okay. So that it might help us to identify how many parents do we have, how many children do we need to have the diapers, how many children do we need for anticonvulsants, and how many children with disability do we have, how many persons with disabilities do we have. Yeah, thank you so much.
Thank you, Sharon. And I sympathize with Sakaja because he's almost in the same space as myself as to what exactly do we need to do here. Oh, you have something? Okay, Johnson.
Thank you, Excellency. I think it's good to be here, and I know many people are from the city. The first issue on occupational therapy, we provide that in our level 4s and in our level 5s. Occupational therapy, physiotherapy. At Mama Margaret, I know we have we're registering. We're doing the registrations, even of PWD. The benefit from free diapers and medicines like phenobarbital. Phenobarbital is available there. We have occupational and basic therapy as well as at MLKH, as well as a serious orthopedic unit over there.
I think she was saying, Johnson, the assessment. He said,
I'm getting to that.
Okay.
Yeah, I'm getting to that. Your Excellency, for occupational therapy, I know for sure it is free at, for assessment, disability assessment, I know for sure it is free at Mama Lucy, Kibaki Hospital. But if it is not free in the other, my CEC is quickly checking, it will be free from tomorrow if it is not. I will direct that it is done. In case it is, that is very easy. And I know they are listening. But I'm just confirming, I know for sure it is free at Mama Lucy. We'll make sure it is free. I don't think you need to be charged for just that assessment, Your Excellency. Thank you.
Thank you very much. Now, there is one thing that is coming out of this, that we may need to expand our, health professionals, scope, to cover new areas. We seem to have gaps in certain professionals. I think somebody mentioned here that there are gaps in some expertise that may be necessary for us to handle situations that confront our healthcare facilities. We need to have the people with that expertise. I don't know whether in this room we have the director of Kenya Medical Training Center. Is he here? Yes. Yes, Daktari, last year we had a conversation. And we had a conversation on, expanding the footprint of your organization. You also brought to my attention that you needed to hire more lecturers so that you can expand the courses that you are offering in our Kenya Medical Training Center. In the context of the conversation we are having, listening to Sharon and the professionals we need in that space, listening to others here, and the feedback we are getting from people, in this year's budget, we have provided money for you to hire an extra 1,200 lecturers and people who will help in your teaching facilities. In this year's budget also, when you did request me, we've also made money available for students at KMTC for Higher Education Loans Board. I think 390 million or so. But I also understand that that money may not be sufficient. And I want to tell the good people, health professionals who are training at our Kenya Medical Training Center, that now, as we improve on the package for tertiary education, we have taken the law to Parliament on tertiary education placement and funding bill that will now cover all students at KMTC to access funding for their training, so that these gaps that exist at the moment, we will settle them. What do you have to say, Daktari, on listening to this conversation? How do we, or how will your organization, with the pool of health professionals that you are training, how will your organization help us and help, citizens who have different conditions, who require different professionals? How do you think we should approach this? And what kind of support do you need from me to be able to provide for beyond what me and you and PS Mudhoni here discussed?
Thank you, Your Excellency. My name is Dr. Kelly Olwach, CEO, Kenya Medical Training College. Your Excellency, to start with, KMTC has increased the number of courses from 98 to 126. That is 28.6% increase in the number of courses. Your Excellency, thank you. We are talking about speech therapy. Your Excellency, Kenya Medical Training College now has a diploma program in speech therapy. We also have a higher diploma course in speech and language therapy, and also a higher diploma in audiology. Your Excellency, I'm cognizant of the challenges that children with disability face, one of which is delayed speech. And Your Excellency, the country did not have specialists in this area in the health field. Kenya Medical Training College, in response to those challenges, has now a diploma and a higher diploma for that program. And the demand, Your Excellency, for speech therapy services is exceedingly very high. I want to thank you, Your Excellency, for leading us into that direction. Your Excellency, I want to also thank you and discuss with the nation about HELB financing at Kenya Medical Training College. Your Excellency, in 2022, Kenya Medical Training College had 54,000 students. Currently, Your Excellency, the institution has 89,000 students, 700. Your Excellency, that is 36.7% increment in the number of student population in Kenya Medical Training College. The rise in the number of students in Kenya Medical Training College is in response to the challenges that the country is facing in terms of shortage of health workers. Your Excellency, one of the challenges that we also faced because of COVID-19 was global rise in demand for health workers. Your Excellency, because of the leadership that you've given us, we have had 185% increase in the processing of documents for those who are going out of the country. And we want to increase that to support our youth to get employment out of the country. Your Excellency, on the issues of training and the issues of HELB at Kenya Medical Training College, it has been an on and off challenge. Your Excellency, the first promise we had for consistent HELB funding of Kenya Medical Training College was in the financial year 2022-2023. Kenya Medical Training College, despite having a growing number of students, did not have a proper way of funding for those students because we exist in the Ministry of Health and not in the Ministry of Education. Your Excellency, in 2012-2023, Kenya Medical Training College received HELP funding equaling to 641 million. In 2023-2024, Kenya Medical Training College got 605 million. In 2024-2025, we got 511 million for student financing. However, there was a shortage last year where our students did not get any funding. Your Excellency, when I brought this to your attention, you were very quick to take action. The first action you took was to request Treasury to assign resources for Kenya Medical Training College. As a result of that, we have 392 million as a stopgap measure to support our students through training. We realize that the number of applicants for help is so high compared to this amount of money. Annually, we will require 700 million for new students and 500 million for continuing students. And so, Your Excellency, you gave a directive through a presidential directive dated 6th May 2026, requiring students of Kenya Medical Training College to get special funding through HELP to support the high number of students who are not getting. Your Excellency, this year's budget has 392 million, and we are also following with the support of my Principal Secretary to get students of Kenya Medical Training College be permanently put under HELP to end the perennial challenges that our students face. Your Excellency, I submit. Thank you so much.
Thank you very much. The good news, Daktari, is that we are changing HELP and combining it with COOPS into the tertiary education, placement, and funding in the bill, so that we combine the placement and the funding, so that for every student we place in a college or a university, we will have figured out the funding for that student. Because the development of our human capital is central to our development as a country. It is the single most important asset that we have. And I just want to give you assurance, and to the students in the Kenya Medical Training College, that this on and off trial and error is going to be a thing of the past. The same way we are funding all our students in TVETs and in universities, KMTC students will now permanently be part of that arrangement. Mercy?
Yes, Mr. President, I know time is far gone. I want to seek your indulgence. As you can see, many notes have been coming my way. My phone is ringing and many messages from the people in the room who still want to speak. We have a team from Moyale. We have persons living with HIV, persons with disability, on local manufacturing, local manufacturers. So if you allow, we can quickly hear from them, and then we wrap it up after that. All right. Let's go to Moyale first.
Thank you, Mr. President. Indulge me because I'm having cold. Yeah, so my name is Getu Samuel Sake. I come from Moyale, Marsabit County. I'm here with a team on this end, and also I'm here together with two elders to tell a story. Mr. President, we are really thankful to you and to your government for organizing this summit. Beyond 2030, we as a team from Moyale, we have a story to tell. There's so many beautiful stories being told here, but we as a team from Moyale as well, we have come to tell a story that is unique to many of you. So if you will indulge me with your permission, I have two elders here. Though language is an issue, I will request maybe a translation that will tell a story, and later on I'll make a submission on the same. With your permission, we have two elders here. On the far end, Mr. Gabayo Osha, and also Pastor Mare. with your permission, let me pass the mic so that they can tell us the story, after which I will make the submission. Thank you.
I'm sure they can speak Kiswahili. Wanaweza kuongea Kiswahili, hakuna problem. Unaweza ongea Kiswahili?
Borana.
Ama iko problem?
Yeah.
I hope nitamsaidia. Thank you.
Makanki Gabayo Washadani.
Kwa majina naitwa Gabayo Washa.
Moyale dufe.
Mimi ni mkaaji wa Moyale.
Uji okan kanisa kesat uji wa aujada.
Nami ni mzee wa kanisa ambaye tunamtumikia Mungu pale.
Kabajama wanenugaran dofnefi.
Mheshimiwa Rais, kile imetuleta hapa
shani Moyale namedun sha infayadama.
Watu wengi wanatumia SHA.
Amo challenge amna.
Lakini tuko na changamoto.
Community ni oja SHA tumitu mgonjwa didiko kubdidik agana insabaibiti.
Jamii wako pale wanapotumia SHA wanasaidika kwa magonjwa madogo madogo.
Amo maro economic areas nami oriti fata.
Kwa uchumi na watu wa huko ni wachungaji wengi wao.
Yo gariboni dufe wanarka kamanam durafuda.
Saa zingine kiangazi inapokuja inawapokonya kenye wako nacho.
Lukubu gurda okani yo fayada bani.
Wanapogonjeka magonjwa makubwa kama kansa na kadhalika.
Achiti yo stroke fargatan, yo accident fargatan, yo lafe facabti.
Wapo wanapopata na stroke na wanapopata ajali na kufunjika mfupa.
Rifaro gar Meru fa korani.
Wanaandikiwa rifaro kupidani Meru na sehemu zingine za nchi.
Meru gar kilomita dibishani oli.
Na Meru iko mbali na sisi zaidi ya kilomita 500.
Adumdemu na mikaradwa.
Tukiwa tunamsafirisha saa zingine watu wanaaga.
Time inachidakabani finamikuni dibu argate karalu buda.
Kwa sasa kwa vile hawatanifikisha pale haraka mtu anafariki.
Namigarillen serikal dibi fade mujariba.
Kwa ajili ya ubali watu wengine wanavuka pande ya Ethiopia wanaenda huko kusaidika.
Akdan samarro full area suno kamfula suni hospitali akdan sa dibgu gurda kan karkarun dandenefi.
Kwa vile hatuna hospitali ambayo ina deal na mgonjwa huyo.
Achi gar Meru dufuitin transport mbeso guddo.
Kutoka Moyale paka Meru kukuja ni transport ni mingi.
No kanisa yo kan committee levelini.
Pamoja na jamii na watu wa kanisa.
Wani afurat Allahni takamin gumi fayad abdikan amna ya jedani yani.
Sikufanya tu jambo la kiroho lakini tukakaa chini tukafikiria tutaweza saidia jamii wetu namna gani.
Akamini diyotoni kunudi hati anna nami karkarsar gata.
Ndio tukafikiria kwa jinsi gani ndo sasa tuwe na hiyo facility ambapo watu wanapata msaada.
Committee wale walagene Moyale community hospital wanjaran obja kasi objanne.
Tukawa na nia na ndoto ya kujenga hospitali ya jamii kule Moyale.
Aknami karkarsar gate ujintun tashayalle akitan saksin demtu.
Ili watu wapate msaada na mambo ya SHA pia ifanye pale vizuri.
Tamisho onane tidaru.
Ya misho.
Debi kun ganadera demu jira area sunit.
Kwa hiyo sehemu sasa hiyo shida inaendelea kwa muda mrefu.
Nairobi odufan disanti mfago.
Wanapokuja Nairobi ni mbali.
Meru mfago.
Na Meru iko mbali.
Yo wikum dabarte wikilam kadabarte jarsi to kakmale fayada be.
Si mbali tu wiki mbili iliyopita kuna mzee alipata shida.
Masa toko lam kesati haraka dakaba jedan hospital.
Walipompeleka hospitali na wakasema mfikishe tu haraka iwezekanavyo within 2 ama 1 hour.
Agmeru dandani wana watu wa dakabon dandanu.
Huyu mtu sasa huwezi mtu kamfikisha huyu mtu yani kwa masaa mawili ama masaa moja afike Meru.
Amma warisune namiyetuna do wakaratu yarsisun dikom ka waqite dakabe hospitali ambai.
Sasa tukiwa tunaomba sasa Mungu akamsaidia huyo mzee akafika hospitali Meru.
Nami tok accident argate yo matafa di bargate ochasun karkar sargachun rakko.
Kama mtu mmoja anapopata ajali apate shida kichwa, kupata msaada ni shida.
Tanafi kabajama.
Kwa hivyo Mheshimiwa Rais,
nullen objutan kamna,
nasi tuko na hiyo maono ya kujenga hospitali ya jamii kule eneo la Moyale.
Akati barchuma guddo fudate nullen ditika fudannu asante.
Nami pia tunakualika ili uweze ukangwana nasi tuendeleze shughuli hiyo.
Asante sana.
Haya, ngoja bwana Gabayo. Akam? Unaelewa Kiborana?
Dasa.
Yoya. Mimi nakuuliza kwa sababu sasa umesema mnataka kujenga I understand ile unaniuliza ni kwamba tuwe na hospitali Moyale ambayo inaweza kushughulika na haya magonjwa umesema yanayozidi dispensary ama health center. Na mimi nataka ujue hivi, unajua Sololo, pale Sololo sasa tuko na hospitali level 4 na nilitumana equipment kupitia kwa wanajeshi wetu, tulijenga hiyo pamoja na gavana wenu. Sasa kuna equipment pale Sololo. What I think my good friend is saying there is the challenge of us having facilities that have capacity in level 4 to attend to some of the situations that now they are going to hospital in Meru. So I think we understand what you're saying, and thank you for the initiative that you have started to maybe build a facility for yourself. But I think meanwhile, we can find a mechanism working with the county government to equip some of the facilities under our national equipment program. We can equip some of your facilities so that they can serve the people of your county. Please explain to him. Thank you very much. I think you can explain to him what I have said in the language that he understands.
Allow me, Mr. President, to pick two more.
Mr. President,
Sorry.
let me just make a submission in a minute.
Yes.
Yeah, thank you so much for your indulgence again. As you have clearly articulated, the challenge here is the distance. And beside distance, this is not interdiction to Moyale General Hospital and Marsabit Referral Hospital. But if you look around even the entire Kenya, those hospitals that are serving Kenyans properly and people are getting service from there are mostly mission hospitals. And within our region, one that we have is Sololo Mission Hospital. That hospital has saved many lives. And the other closest, which is nearly 500 kilometers away, is Kirua Mission Hospital in Meru. And now looking around the issues that we are seeing, why are we here as a church? It's because if most of the time we go out on a medical camp, and the most experience, the challenge that we see and witness every now and then is that there is that recurrent issue, especially around Kargi region in Chalbi area, Kargi to Sololo to Moyale. There are cases over decades, cases of cancers, especially throat cancer and stomach cancer. One good case example is my Shosho. My Shosho passed away back in around 15 years ago. She passed on with cancer, and many other cancer cases are there. Just imagine the distance between Moyale to Nairobi, or the distance from Moyale to Meru, that is alive. So the challenge here is the challenge of diagnosis, after which there's issue of treatment, and look at the distance. All this issue is really troubling our people. That's why we are saying, as a government, kindly we request that if these facilities, as you have clearly put, if it can be brought closer to us, probably Marsabit or Moyale, it will be helpful. So in that endeavor, we as together with other stakeholders, especially faith-based organizations, we have been keeping in touch, we have been talking, and also the communities around and other stakeholders. We try to reason, and we said we will put up a hospital that we seek mobilization from different areas. As a result of this church, they were able to provide 8-acre piece of land for such a mission hospital to be built. And so as a result, they have consulted different organizations, and already plan is underway, and they have already started construction. Therefore, here, as a team here today, as we address the plight and issues facing the northern region, because most of the time, let me say this, Marsabit and Isiolo, most of the time they are being confused with northeastern region, that is Garissa, Mandera, and Wajir. Most often we get lost under there. But we, those there, you know, those are the northeastern, but the actual northern, those who are there, we face these challenges. The challenge, the Moyale General Hospital, it's south the border.
Excuse me, if you allow me just to interject, Mr. President, I'm being told there is a level 5 hospital in Marsabit that is currently undergoing construction by, this is from Dr. Wilson Arwasa. I don't know if he's in the room. Maybe that can...
I think Duale is here.
Duale.
But,
Okay.
but I think the point he's making is that we should make more facilities have equipment that can help in the treatment of
Yes.
cancer and all the other. And I think this is a matter that had already been spoken to by the chair of the council earlier, that we need to assist counties to be able to have the requisite facilities, especially on matters to do with cancer, because it's a real disaster in many communities. And in the past, people had to travel, you know, to Nairobi and to all the other places. With now the elevation of some of the facilities to level 5, we should be able to make those facilities available, you know, in those hospitals, so that we can deal with the case of Moyale.
As I see it, kindly allow me to present this document. One, here we have a concept paper on our project, as well as
Please,
an
you
invitation
can pass it on to
for
the gentleman
you
there.
to attend in our fundraiser. Thank you so much for your time.
Thank you.
And God bless you.
Thank you.
Thank you. Thank you. Thank you for that. Thank you, Mr. President. Allow me to bring in 2 more based on our conversations yesterday night. We discussed a lot about the equipment, services, and local manufacturing, availability of medicines. And I'm told we have a local manufacturer of, I think, medicines that would want to speak. And then we had a conversation about registering Kenyans to SHA. I think the number is, once a country is at 85%, then you are well on the way to UHC. And Mombasa County, Governor Abdul Samad, as that yesterday, was at 84%. And the co-chair of the UHC 2030 would want to comment on that. So allow me to pick on those 2, on the local manufacturing. Behind me. Okay. Who? Him. All right. Your name just in under 1 minute, please.
Thank you very much. Your Excellency, the President, all the dignitaries, my name is Dr. David Maina. I'm a pharmacist in the field of local manufacturing, and I'm here on behalf of my fellow colleagues who are manufacturers. We want, first of all, on behalf of the local manufacturers, to greatly thank you for this audience and for your commitment towards universal health coverage. We are very grateful. We've actually been looking for such an audience for a long time, and this is the right time. Your Excellency, we have about 40 manufacturers, local manufacturers in Kenya. The 40 manufacturers produce medicines and take care of about 30% of the local consumption. Your Excellency, that's very key. Because what that means is that the other 70% is not made locally. That means it is imported. Let me also emphasize that the percentage is not in terms of the number of packets of medicine, it's a value. So if the local manufacturers are doing 30%, the 70% imported is high value. And if we did it locally, it could cost us maybe 30% or 40%. Having said that, we also, as a manufacturers, we employ about 1,500 people, about 15,000 people directly, and many more in the value chain. So local manufacturing is a very, very important docket. When I heard many people talking, Your Excellency, they were all referring to medicines, dawa. In fact, some said, unatibiwa, unaambiwa hakuna dawa. At the end of every service delivery, health service delivery, is a product. That is the dawa. And that's where we are placed to ensure that we provide those medicines to the patients so that the whole ecosystem of treatment can be complete. When COVID struck 6 years ago, there was a general crisis in supply chain of pharmaceutical products. In fact, Kenya could not even import a simple sanitizer. Even masks were being imported, that used to be imported, we had a shortage. So I'm saying that because our space, and why this is very important, has two aspects or very objectives. One is to play our role in universal health coverage in terms of supply medicines, quality, affordable medicines. The other very important one is actually disaster preparedness. If another COVID came, that would be a disaster. Would Kenya be prepared? How prepared are we if we are importing 70% of our medicines? It's a big security threat to this country and all the countries in the region. With that, let me acknowledge your support, Your Excellency. 2024, about 2 years ago, we were here at KSAC, and you gave a commitment that Kenya need to carry from 30% to at least 50% supply of local produced products by, I think, 2026, end of this year. With that, I'm happy that we have gotten very good support. Let me give credit. We have a very good Ministry of Health that is very supportive, extremely supportive. There's even a Department of HPT, Health Products and Technologies, at MOH that is supportive. In fact, recently, they mined all the data and have a local manufacturing, pharmaceutical manufacturing strategy that was recently. That is very welcome. We also acknowledge, Your Excellency, that you are actually the champion of pharmaceutical manufacturing in the region, the IGAD region. And we are proud that our president is actually the champion. We have good support. However, we have some challenges that we are facing that are preventing that achievement.
Sorry to cut you, if you could just make that brief and maybe do it in a minute.
Yes. I'm going to be very brief. We have some 4 challenges I'll highlight that are making that achievement scaling to 50% become a bit difficult. Why this is important? Because despite the support from MOH, we feel that the challenges cross across the ministries. And it's only probably from your level that that can be sorted out. I'll be very brief with that. Number one is the cost and the competitiveness of our local products. We have a situation whereby our inputs are very expensive. Because of compliance with quality, and especially now Kenya is undergoing maturity level 3, ML3, our factories are very expensive to run. High electricity bill, all the inputs very expensive. In addition, we have taxation that is not pro-local manufacturing. Especially, we have excess duty on packaging material. Recently, there is VAT added on some raw material. I know that's being sorted out. Why that is, let me add that despite that, we have import duty that is exempted. That's very good. We don't pay import duty. We don't pay IDF fees. We don't pay levy. That's very welcome. But the few things that we pay, like excise duty on packaging material, it's making our products very expensive. We have been engaging MOH for the last 3 years. And we feel that there is a disconnect between MOH and Treasury. Because Treasury on one side says that they need to protect local printers, local paper manufacturers. So they put excise duty on imported packaging material at the expense of pharmaceutical manufacturers. But we can sort out by actually ring-fencing the local manufacturers only. That is an example that imported glass bottles have excise duty into bracket apart from local pharmaceutical manufacturers. That can be done for packaging material. But that has all been done for the last 3 years, and we kindly request, if that can just simply be done, we'll be more competitive. The costing part of it also, we are competing with imports, the 70%, majorly from Asian countries. Those imports from their source have been exempted all the duties, and in addition, they get export subsidies where they are bringing to Kenya. You find such that you're competing with a product that is all exempted, well covered by the government, and you're competing with it here. That is us the competitiveness that we are asking for. Number two challenge, because I would be brief, is about regulatory challenges. Among the 40 manufacturers that I mentioned earlier, inspection by Farmers Advisors Board last year, and it's a good inspection because it is towards maturity level 3, which we fully support. We are in full support of level 3. We think it's a good thing. But despite that, that inspections made 12 companies be suspended their licenses. That means from the 40, you hive over about 1/3. What that means in short is that if you are doing 30% supply to Kenya, you are removing 1/3 of it. You are left with 20%. So we are likely to be in a worse position now, although it's temporarily because of the inspection, than we are then. The other part of the regulatory challenges is that those countries we are competing with, where they are registering a product, they take 3 months to 6 months. In Kenya, we take about 12 months at best to 36 months. That means if we want to have more products, 50% achievement, we have to register more products. There needs to be a fast-tracking method to have those products in the market. Your Excellency, you mentioned, and rightly so, that you negotiated reduction of price by one foreign company from a certain figure to 1/3. The question is, they were making profit when they were at 100%, they are still making at 30%. That's the kind of level we are losing by importing. If those resources in foreign exchange can be put in local manufacturing towards the taxation and other cost remedies and support for registration, we will actually achieve that faster. Number 3, and I'll be very brief, is about capital. Okay? We have a system whereby it is very capital intensive to run pharmaceutical companies. Just the way we have other funds for agriculture and other departments. If we could have a pharmaceutical industrial fund, and we don't want goodies, we don't want anything for free, just easily borrowing and payment, it will help a lot. Because banks perceive pharmaceutical manufacturing to be a specialized field and therefore very risky. They are not willing to maybe buy a machine that is not universally used by other people. Finally, we have KEMSA, which is the biggest purchaser of our goods. KEMSA and county governments. KEMSA and county governments have a policy of the lowest price. That means the initial challenge I mentioned about the competitiveness applies when you're tendering for KEMSA. You find that the imports, we can't compete with them. Therefore, despite maybe a 15% allowance, is not enough to attract many local manufacturers to sell more. And even after selling, and this is where the KEMSA needs to hear, takes about 6 months to 1 year to pay. If that can be sorted out, we'll scale up to more produce manufactured. We are ready to support you, Mr. President. If we can have that support, we can actually make quality, affordable medicines, not just for our country, but even to export to our region. Thank you very much.
Very well put, Mr. Maina. Yeah, very well put. I have a couple of questions for some. I think we need to answer this question. I mean, we have transitioned. We were saying initially financing is critical. And then we said human resource is critical. Now we have gone to, without medicine, there is no healthcare, according to Maina. So everything in the chain looks like it is critical. Agreed that we're producing only 30%. That was in 2024, we had a conversation. And my instructions to KEMSA then was we give priority to locally manufactured products. I want to understand first whether, and I had even specific examples. I had, for example, one facility in Kilifi, Revital, and I think they are here. And Revital was manufacturing a lot of stuff in Kenya and could not sell to Kenya, but they were selling to other countries. And it was because of a conundrum at the KEMSA. And I said that should be undone. I don't know whether the CEO of KEMSA is here. Yes. Can you explain to us, I know there was another CEO, what is how has things changed in terms of your purchases? We insisted that local manufacturers should be given priority. Specifically, are you now buying from Revital and they are here? If you say something that is not correct, they will say something different. Just tell us.
Thank you, Your Excellency. Yes, so local empowerment is very important, including manufacture of pharmaceutical products. We are keeping a tap on that. Revital can attest that nowadays they don't complain, they don't write letters. We do a lot of procurement from them. But in general, under your direction, we got instructions in order that we should do more than 40%. I can attest here that our procurement from local manufacturers is 52%. And in fact, from international manufacturers through our local suppliers, when you add those two, over 70% we buy locally. So the preference in procurement works when there is an international competition. We give, according to the Public Procurement and Asset Disposal Act, we give 15% preference to the local manufacturing. And by local manufacturing, 100% fully owned by Kenyans, or more than 50% owned by Kenyans, they enjoy a 15% discount. The only trouble comes in, I think Dr. there has talked a lot about other issues outside us, which affect their costing. So as a government, maybe that can be looked at. But yes, we do, and
Thank you very much. Thank you very much, Wako. Revital. Yes, please pick the mic.
Mr. President, thank you. I represent Revital here. I would like to attest to what Dr. said. Yes, we have been getting local tenders and we are able to get that preference. However, mobilization of funds after the supplies is something what we are still chasing on. So
okay.
one tick box checked, but the second one is still in the progress. And just to add to what my colleague said, Just like our neighbors, they come up with policies like BUBU, like Buy Uganda, Build Uganda, wherein they are giving preferences to the local manufacturers by increasing some taxes for the imported medicines and products. We are also looking for support from you on that.
We will go there.
Yes.
I will go there shortly.
Sure.
So I just wanted to confirm that we have moved our locally manufactured products in KEMSA from what it was to now you tell me 52% of your purchases are from local manufacturers.
Yes, Your Excellency. I only have one problem with the manufacturers, which I'll take the opportunity. When we strictly label the advertisement to attract only local manufacturers, then they tend to hike the price because they know the international bidders are not in. So I plead with them, when they see it's restricted for local manufacturers, we are a commercial entity. So if they don't give us room for markup, we'll not be able to pay salaries.
Minor, there is some homework for you and your team there. You know, we do not want you to shortchange us. You know, the moment we lock out your competitors who are international, you must not do a cartel business here and hike prices, you know, really. Because we really must be honest with ourselves, because this is public money that we are using, and we want to get value for money. So I think the issue raised by the CEO of KEMSA is an issue that you must address so that we can support local industry and still get value for money for the Kenyan people. We do not want to say, because it's a local manufacturer, then we pay more than, you know, is reasonable for us. That is one issue. But my instructions to KEMSA was that progressively, we must get value for money, but we must support local manufacturers. You have raised a couple of issues. The first issue is we will do affirmative action. I want to confirm to you, we will do affirmative action on buying from local manufacturers. That is number one. And I want to encourage counties, when they too are buying, let us try and see how we can support local manufacturers. You have raised some issues on taxation. We did what Maina said. We removed some taxes, IDF, all the other taxes. You are telling us to go further and, you know, ring fence, because, you know, we do not want a situation where we are promoting local manufacture in one space and we are undermining another space. When we put duty on imported paper, it was because we also wanted to support local paper manufacturers. So we must also balance between manufacturers of local paper and the pharmaceutical industry who may want to use paper that is not locally manufactured. And what we should be able to do, and I think Duale, your colleague in industry, Lee Kinyanjui, and Badia Treasury, you should be able to sit down and encourage local paper manufacturers to manufacture the paper that these good people can use in the pharmaceutical space, so that we have we sort out both sides. And now we will be willing to have a conversation, Maina and your team, on how we can bridge the gap between local paper manufacturers and yourselves, and whether it is absolutely necessary to ring fence paper for packaging for pharmaceutical companies in the manner in which you have suggested. Number three is we are trying to transition the country to ML3. And, you know, we have to meet certain conditions. If some of our local manufacturers don't meet those conditions, you know, we will undermine the position of the country if we don't meet certain international conditions. So unfortunately, we will have to, you know, to ask some of your local manufacturing entities to up their game, honestly. And the Duale and the PPB people in Duale, do you want to say something?
Excellency, I know Maina very well. And I had a session with the Kenya Pharmaceutical Association more than 5 times. Today, under your leadership, we have done the reforms that has never happened in our country under BPP. And I want to share this with you. Number one you have answered. Maina is telling us to protect local manufacturing. But the same miner wants to go and import packaging from outside, and then we remove duty. All that we're telling miner is there are competent companies in our country who do the printing of packaging and who gets that favor from the National Treasury. To Your Excellency, as we transit to ML3, which you have directed, I mean, Kenya is big, it has a big pharmaceutical base for the country and for the region. Kenya is about to attain ML3 by October this year. For us to do that, we have stopped all parallel importation. Because parallel importation was where a lot of fake and counterfeit medicine used to enter our country. In fact, 2,500 products have been removed from the system of Pharmacy and Poison Board to make sure that we, number one, for the safety of our citizens and the dignity of our patients, we must stop counterfeit and fake drugs. So 2,500, there are many people who are complaining. Number 3, Your Excellency, and I think Maina must be be aware, is that for you to establish a pharmaceutical manufacturing firm in our country, all the equipment and machineries are of free duty. They have a huge, no any other country in our region gets that kind of tax incentives. All they need to do is to get a letter from the Ministry of Health to the Minister for Finance, and the Minister for Finance will write to KRA, and they get all the incentives. And that is what we did in the last 4 years. Today, there are more than 12 new manufacturing pharmaceutical companies now. 2, when you created the incentives that the local manufacturing preference be done by KEMSA, a lot of now Kenyan investors, working maybe with other foreign investors, are now establishing their farms in Kenya. So the reform that we are undertaking, I know the one that he wants me to talk to the Minister for Trade, Minister for Finance. We are in engagement. But again, we must balance. The kind of incentives our pharmaceutical industry is gaining, Your Excellency, is so phenomenal that the element of the packaging, which is very important, all that the National Treasury is saying is that we have given that incentives, that tax incentive to locals, not that you bring it from outside. And I can confirm that Revital, under your direction, and all other companies, what the CEO is saying is true. What they used to do before is they used to mix things, and you're aware of that. Now they're doing specific procurement for specific items. So Revital, unlike before, now they sell to. On the issue of the payment, I think that is now a commercial interest, 90 days, 45 days, 60 days. Social authority under their contract is 90 days. So I think that's something we can discuss. But Your Excellency, the reforms that you asked under PPP is on course and is for the benefit of the country.
Thank you very much. I think this is a fair conversation. Maina, you agree. It's a fair conversation. I think you have asks. They must be, balanced with other, but I think if there is one space that I am very confident about, especially after the meeting I had with the manufacturing community in Kenya, pharmaceutical manufacturing fraternity in Kenya, we have provided sufficient incentives to make sure that those who want to set up manufacturing capacity in manufacturing facilities in our country do so. We have even extended, just for your knowledge, Minor, the special economic zone in Thika. We have said that special economic zone should be made available for manufacturers who want to benefit from incentives in a special economic zone space, long-term investments and all the other things. And we have already provided the first phase of infrastructure in Thika for that space. However, I think we still need to have a conversation about us being able to meet our financial obligation to these good people so that we don't undermine their business. And I thought we provided a facility to KEMSA of 10 billion shillings so that you can be able to pay your suppliers, you know, when it is due, as you wait for the counties and all the other people to pay you. How about, what are you doing? Isn't that some place where you can see how to manage the financial outlay of these manufacturers, especially the local ones who require support?
Thank you, Your Excellency. Yes, absolutely right. I think financial sustainability for KEMSA is something we've been working on under your leadership and the Cabinet Secretary. I really want to thank you for taking it head on. So we have a lot of issues. I know governors are here, the chairman is here. The payment cycle, picking orders and paying for it takes a long time, thereby also affecting our own suppliers. So that facility, yes, I can confirm, it is on. We're just waiting to sign an agreement between the counties, ourselves and SHA, so that we have an automated system to go the full 10 billion capacity. As at now, Your Excellency, I can confirm the national referral hospitals, just to give example of what financial sustainability can do, have already signed under the leadership of the Cabinet Secretary. We have signed with the 7 national referral hospitals an inter-parties agreement. Now that has allowed us to get the facility up to 1.5 billion, and that we have already started engaging the suppliers on that. Then when we sign with the COG, chairman is here, and we're working very, very closely with the chair of Health Committee. I even flew to Mombasa to discuss that with him, and I think the future looks very luminous under your leadership. Thank you very much, sir.
Thank you very much. I would really want to persuade my good friends, the governors. I think it is good for all of us. I mean, the principle, and I think we can have this of this stage, the principle is for us to have a complete cycle, that instead of a check-off system, kind of, with SHA on the drugs bit. And I think that's a conversation we can have that will improve the financial ability of KEMSA to procure drugs, and it will also help our manufacturers to be paid on time. I think if we can do that, it would really be very helpful. Yeah, Chair, would you want to say something?
It will be good to have an aged data of all the counties to see where they are, because as disbursement flow from Treasury improves, that should also, help them pay faster. But we're also willing to take up that conversation. We have had that conversation of some arrangement, which is debt discounting in a sense, or whatever arrangement that KCB is willing to take up to help counties pay much faster. Our Chair of Health is here. It's a conversation we're willing to have. But also, if there's just some chronic, late payers, it's a conversation we'll also be willing to have with you. Some of us always only have the last order payable. And whenever we get our money, we prioritize KEMSA. So let's see if there's any problem of age debtors, and then we can have that conversation. As for the KCB, it has to be county by county, but I can get an in-principle approval for, from the perspective of COG. Thank you.
Chair, do you want to say something brief? Very brief. I don't know, we have run out of time. I think my good sister there will run into trouble.
Your Excellency, it's true. I did meet with Dr. Wako, and I did present to the full council the various options. One of the things, Your Excellency, that I think if we finalize, and we can even be able to finalize this on Monday, either at IBEC or something, there is a possibility, Your Excellency, by coincidence, the amount of money that counties have to be paid, and verified amounts, is about 5 billion by the former NHIF. Which actually is another example to show that NHIF was not working, because 5 billion was actually due to be paid to counties. There's money that Treasury has already dispersed actually to SHA that was meant to be to pay for NHIF. The agreement that we are proposing is, instead of giving us that money, we do a debt swap. And an example is a county like Mombasa that has money to be paid but does not necessarily have money to pay to KEMSA. We'll do a drawdown mechanism. Same thing with Nairobi. The difference from the amount of money that Nairobi has to be paid versus what it is that they have to pay is almost 700 million. If this is acceptable, Your Excellency, KEMSA gets an immediate financial injection of 5 billion shillings. 5 billion shillings injection of money. And the other one now is so that we do not have this problem back and forth, and we do not sit here after 5 years saying that KEMSA has to be paid and we're in the same dark hole again. We were proposing something that the counties can be able to give some form of a guarantee. I know there was a proposal of deduction at source by SHA, and we came up with another proposal because, and upon discussing with the CEO of KEMSA, it is something that excites him even more, because a facility, let me not get into the very, very much nitty-gritties, Your Excellency. Those are for behind the tent discussions that we will have, but we have the goodwill to be able to finalize this.
Thank you very much. Are you trying to use KEMSA to collect your debts in some way?
Not at all, Your Excellency. We all we are saying is that we have a solution to be able to, first of all, give a direct injection of 5 billion to KEMSA. And with that in mind, bearing in mind that counties like Mombasa and many others that actually do not have to pay KEMSA, but we have to be paid, we are proposing that don't even pay us. Give that money to KEMSA and we'll do a drawdown mechanism.
Okay. Understood.
Yeah.
Understood, Chair. I think the beauty of this conversation is that every matter that has been raised here, there is already an active conversation going on. There is an active engagement, either with the ministry or with the county government or with another stakeholder, giving us the right impression that we are, to a great extent, on top of the ball. We know where the issues are. Some of them are being sorted out. We need to accelerate some of them, and we need to do what we have to do to smoothen the delivery of health journey in our country. Mercy.
Thank you, Mr. President. Allow me to just welcome one more comment, because we are looking at health beyond 2030, and the co-chair of the UHC 2030, Dr. Githinji is here, and he had a comment about we are at 60% registration, 25% more for Kenya to be well at the journey of UHC. After him, you can give your closing remarks and close the summit and this particular town hall. Thank you.
Yes, Your Excellency, thank you very much. I have been seated here yesterday for about 5 hours, today for 5 hours, I feel for you. I don't know how you're feeling because you're the man in the center. And that's not easy. I travel around the world, number of works across Africa. This kind of engagement at presidential level on health is very unique. We don't have it. So thank you very much. Thank you. Again, we don't have a lot to say because we are, sisi ni mafundi huko ndani, we are working with your team here as AMREF very closely. So we are listening as well to just know what improvement is needed. But let me just make a few comments. Number one is that it is without doubt that we congratulate your government's very expansive reform for the health reforms that have been done. We don't often see such extensive reforms. We see one act after another, you know, small, but this government has taken the bull by the horns. And those reforms are not seen anywhere. I've not seen them anywhere in any other country in Africa, honestly. But we have worked with the other countries on one-on-one, but this is really expansive. Now, I want to believe that this conversation, as you said earlier yourself, is not about the next election. It's about the next generation. And because this conversation is about the next generation, then we need to think about this conversation beyond the Social Health Authority. We need to think about it that, for me, when I think about it, I reflect on the fact that there must be a reason why you did not call it Ruto Care. You call it Social Health Authority. Because you saw it beyond, you saw it as something for 2060. Just like we've had NHIA for 58 years, we see this as the thing that's going to hold us together for the next number of years and decades that come. In which case then, I tend to think that we should discuss it honestly. And we should actually, as Kenyans, and I'm really grateful that I've had a lot of conversation. By the way, I chair the board of management for Mbagathi, appointed by Governor Sakaja. So Shikuku, you pointed at me a bit, so I was a bit shy, but I will see you behind the tent, Taonana, over the X-ray. But this conversation needs to be very honest, and I think that's what you're inviting us to do. We need to be honest that this is not President Ruto's scheme. This is actually something owned by Kenyans. And therefore, if it's owned by Kenyans, then Kenyans must be honest to engage on it and say, this is how we must improve it, because this is what we have, and this is what we are going to have for the next, you know, so many years and decades and decades. And therefore, all those conversations that, and you have a team here that is completely able to solve those challenges that are being raised. So I don't want to make that the subject of the conversation. We know, of course, there are civil society members here who support the government. Is there anyone here from civil society? Just raise up your hand so that His Excellency can see how many we are. Civil society, that's a civil society group, Your Excellency, that is spending the days here with you. And we support the government, the county governments, the Ministry of Health, to ensure delivery of the government projects that you have. Now, the key issue that we see here is that there's a danger. Health financing is actually very emotive, extremely emotive. And I know through the reforms you've had, it's been a very emotive discussion. But it kind of tends to bury the conversations around wellness. It tends to make them invisible because it's so emotive and tangible that you're talking about how much to finance. But the bigger conversation, as the Kenya Health Summit says, is about health. And I think that beyond just talking about health care and how to finance it, which is valid and what everyone else is talking about here, we, with your leadership, need to have a conversation about building health and wellness. And that, of course, starts with SHA, but is beyond SHA. And one of the issues that we see within SHA, and then I can go beyond SHA, is how we can have conversations around legislating and ensuring we optimize level 1 of the health system, community health level 1. And to optimize that, we already have the work you've done, the community health promoters. I can tell you that I've spent my 11 years at AMREF negotiating for governments to actually invest in community health workers at multiple levels, international, regional, and national. So for us to see that realized and have 107,000 that are receiving stipends, that one deserves a congratulations. So thank you very, very much. And that, starting at that level, then we ask ourselves, how do we actually optimize this investment entirely to build health? Health means that we identify diseases early, but we also build lifestyle change within the communities using the level 1 so that we avoid the dialysis, so that we avoid the ICU care. Because I can tell you, and I know you know these numbers, that Kenya, at best recovery at 15%, will not get more than $100 of public financing per person per year. Not more than 10,000. That already what we are doing is very, very good ahead of other countries. Well, we haven't achieved 15%, but we can see we are moving towards there. But even if you reach 15%, you will not have covered the amount of money needed to provide health care, not health care to all 56 million Kenyans. Whereas developed countries are spending $4,000, $10,000 per year. We are spending 50. So, and we can't change it. It's the nature of our economy. We can change it constructively as you're doing with taxation, more this and that pulling. But at the end of the day, we must realize we cannot get ourselves out of health care with money. So we have to discuss how to build a healthy population so that we avoid the future costs that SHA has to pay. And for that, we need to think about the community level. We need to ensure there is a policy framework for them to ensure they can actually do the thing that they do in other countries. Integrated community case management, looking at pneumonia, malaria, and all these things. That requires a conversation with the Ministry of Health and all the policy workers. Secondly, the commodities that they use. They need to find a pathway within policy so that they are not a second thought, like you say, we need now to refill the kits. We need to work with the counties to ensure that they are within the procurement and the Kenya Essential Medicines lists, and that conversation can be had. Finally, it is to enable the primary care networks. They are really critical to your legislative agenda, but they have not been fully operationalized. I think we have worked with the Ministry of Health to develop a primary health care regulations that should help operationalize the primary care network, because when that's operationalized, then we have a better referral system, and then we have a much better conversation on health. Finally, I need to bring the issue of wellness. That wellness is beyond health care. It's health. And one of the issues I would like to put on your table, Your Excellency, with your permission, is the issues around food regulation. The reasons that you see hypertension, diabetes rising, we see increasing demand on dialysis, is because we have actually left the food environment unregulated. We have people consuming sugars that are unregulated. We have people consuming industrial trans fats that WHO has put a limit on. We have advertising of sugar to children. In the supermarket, the sugar products are right at the counter. The people selling them to us don't allow that in their own countries. So my urge to you, Excellency, is to drive an agenda to reduce the burden of disease in this country by actually starting to talk about food regulation as a public health investment. I think if we can do that, the cost of SHA in future will reduce, and we'll have achieved wellness for the country for the next generation, not for the next election. Thank you, Your Excellency. Thank you.
Thank you. Thank you very much. Your Excellency, you can give your closing remarks.
I think that is a wonderful place. You know, that's a wonderful place to end this conversation and to end this summit on health. We have had a wonderful engagement. I have really benefited from this engagement from yesterday and, of course, in this particular setting. I want to thank all the people who have participated. We have our mothers who are here. They are part of this conversation. We have people with different conditions. They are part of this conversation. We have manufacturers. They are part of this conversation. We have health workers. They are part of this conversation. And it couldn't have been more inclusive. We have members of parliament here. We have members of the Senate. It couldn't have been more inclusive. We have people online who are following this conversation. I think we are having a conversation of a lifetime as a nation, because health is a very serious matter. Kidinji has, brought us a different perspective as we discuss Kenya beyond 2030. Yes, we will discuss how to manage disease, how to provide better equipment, better facilities, train better doctors, and all do all that. But he's reminding us that we can do this also much more effectively in preventive and promotive care. It is the reason why my first step was to bring community health promoters on board from day one, and to make them part of the health ecosystem in law. So today our community health promoters are part and parcel of our health equation. What KBC is telling us now is, while that is okay, we now need to build capacity for our community health promoters. We are not maximizing what they can do. Yes, they have gone to all the households, but we need to equip them. We need to, build the capacity of community health promoters. We're giving them a stipend today. I think we will have to think seriously about how community health promoters will play that extra role. It cannot be on stipend. It has to be in a different format. So again, this is a beautiful conversation, really. And we also need to move to the space where we control sickness from what we eat. I think that's what KBC is telling us. That is the conversation we must have. And that is why Kenya Beyond 2030 is a healthy conversation for us. We should be able to think health beyond medicine, beyond hospital. So thank you very much, KBC, for bringing that perspective to this conversation. I think we now have some topics for us to discuss as we discuss Kenya Beyond 2030 on matters health. And that is the beauty of this engagement. The fact that we've come here to listen. And I think everybody has had their say, and we have benefited in a very significant way from this interaction. And as a country, we are the richer and the better as we engage in this manner. The reason why we held this summit could not have been any different. I think we've had the outcome that we looked for. We have some homework to carry home, some of us, and everybody else have picked their piece. I want to say to all of you, thank you very much for your participation. I very, very sincerely appreciate everybody who has made this conversation the success that it has become. Asanteni sana.
Ladies and gentlemen, I'm sure you'll agree with me, if commitment was a person, it is His Excellency. Why don't we give him a very, very, very warm clap? 10 hours seated right there is not an easy thing. Your Excellency, you're leading from the front. Let's also appreciate Dr. Mercy Korir, and for your information, she is a medical doctor with a passion to communicate matters medicine. So please, let's give her a clap. Thank you very much, Dr. Mercy Korir. We'll all now be upstanding as we finish this session with the national anthem, the anthem. We'll allow His Excellency to exit, but maybe a quick photo with Dr. Mercy before he exits. And then after that, kindly let's hold our positions as we get ourselves ready to allow